A very good morning to all of you and welcome to this session of OSWB Academics Walking Hand in Hand. This program was started in 2020 and is still going on with the concept of embracing equity, that is inclusiveness. I'm very happy to see so many of you here today on a Sunday morning. Even after you have to give your family time and other engagements, and still you have managed to come here. Thank you so much for coming here. So instead of wasting any more time, I would start our program with our customary process of welcoming our President, sir. Please request our President, sir, to speak.
Good morning. I welcome all of you, especially so many renowned leaders coming outside from the state. I really welcome, thank you. And I congratulate Sudipta on behalf of OSWB for organizing such a beautiful program. Thank you. Carry on.
Shogata, can you please start the video? Started from the beginning.
No.
This started from the beginning, please.
Walk hand in hand with me through all eternity. Have faith, believe in me. Give me your hand. Walk hand in hand with me. Walk hand in hand, walk with me. Be not afraid, for I am with you all the while. So lift your head up high and look up to the sky. Walk hand in hand with me. This is our destiny. No greater love could be. So lift your head up high and look up to the sky. Walk hand in hand with me. This is our destiny. No greater love could be. So lift your head up high and look up to the sky. Walk hand in hand with me. This is our destiny. No greater love could be. So lift your head up high and look up to the sky. Walk hand in hand with me.
Probably you have looked into this program. The term walking hand in hand here has the concept of two ophthalmologists, a male ophthalmologist and a female ophthalmologist, walking together in the same topic and discussing the same topic. So that is the theme of the program, inclusiveness. We are all equal above all bias. So now the first program is on cornea and oculoplasty, and I welcome the moderator of that session, Dr. Shagnik Shurjodash, to take over for that. And the first participants, I think Dr. Shoham is absent, right? He will be a little late, so we will start with Dr. Joita. Welcome.
Good morning, and it's going to be a wonderful session. And Shudipta Di has already introduced. So we have our chairpersons for this session, Dr. Debashish sir and Dr. R.C. Paul sir. And panelists for this sessions are Dr. Kasturi madam, Dr. Somashila madam, Dr. Parthabisha sir, Dr. Chandana Chakraborty madam, and Dr. Saurabh Shannal. And can the panelists come a bit front, up top? Okay. Okay. So since Dr. Soham, the first speaker we have, he's running a bit late, so we'll start with Dr. Joita and Dr. Rajesh Mujumdar Chaudhary sir on the topics of fabulous flaps. Dr. Joita, madam, please you can start.
Good morning, everybody.
And Dr. Rajesh sir, can you come up?
Good morning, everybody. Thank you, OSWB, especially Dr. Sudipta Mitru, madam, for this kind invitation. Without wasting any time, I'll start my video first.
The fabulous flap. Flaps and grafts are the most indispensable technique of Apollo plastic surgery. This is a video of nasojugal flap with combined tarsal graft to reconstruct a large lower lid defect in a case of 45 years old lady with a recurrent suspected lower lid malignant lesion. After induction of general anesthesia, the lesion is marked keeping a 4 mm safe margin on each side as per the oncology principle. The proposed nasojugal flap is marked on the lateral nasal wall, keeping length and the base with ratio of 4:1. Local anesthesia was infiltrated and the lesion was excised along with the marking with a radio frequency knife. After excision of the mass, the defect is measured and replicated in the upper lid tarsal conjunctiva, leaving 4 mm margin intact. The tarsus is then dissected from the overlaying muscle up to the molars muscle insertion. Tarsoconjunctival flap is sutured with the remaining lower lid tarsal stump by vertical matrix suture. The base of the tarsus is then tied with a lower lid retractor and the conjunctiva with a 6-0 The flap skin incision is started and the dissection is carried out at the subcutaneous plane and extended upwards. The dissection is deepened gradually to the pre-periosteal plane. Surrounding tissues are undermined. Then the flap is transposed to cover the tarsoconjunctival flap to form the anterior lamella of the lid. Anchoring of the flap to the periosteum is done by 5-0 Weichel suture. All remaining gaps are sutured in layers and conjunctiva is divided at the end. Post-operatively, the flap is healthy with an excellent surface closure.
Sorry, we have run out of time.
Can you just go to the last portion?
No, this
where
is
you
the
want
last,
to-
madam.
Okay.
This is the last
Okay,
slide.
let
Can you
it-
please show the last
This is
slide?
the last one.
Thank you.
No, the post-op result I just want to show. Last that's result of this. Okay, I can show it. Just a minute.
Just come to the end, please.
In layers and conjunctiva.
I'm last to
The flap is healthy with an excellent surface closure. The advantages of the flap are they provide the best possible match of skin color, texture and the function of the lid. Thank you.
Thank you, sir.
Thank you, Dr. Joyita. Dr. Rajesh Majumdari Chaudhary, sir, please.
Have you started? Okay. I have a patient here of coloboma, LaLit coloboma with cardiac anomaly. So we decided to close the gap with the Tenzel's flap. This patient has had a univentricular heart for which some procedure was done and he was some blood thinners. So here I'm raising the Tenzel's flap. You can see I've done the canthotomy and cantholysis, and I'm going beneath the orbicularis muscle above the temporalis fascia, and thereby I'm raising the flap first. And after that is raised, now what you have to do is we have to ensure that the margins of the coloboma are made raw so that they can be stitched properly. And what I do here is that some people sometimes say that you can just rub a 15 butt plug a knife, but I find that actually it does not work. I have to really incise and excise the tissue so that there is a substantial area of apposition between the two portions of the coloboma. Here I have released the superior canthal ligament a little bit. Be very careful while you do that because you may damage the lacrimal gland, so be careful about that. So suturing the opposing ends with 6 of Vicryl, and then basically putting a couple of sutures, one through the gray line, other through the lash line. Then again, suturing the muscle and the skin. Usually in this kind of cases, there is a slightly crunched up levator superiorly. So to give a better cosmetic result, we usually excise that and then we suture it again. So skipping a little bit. So excising that area of bulge. Suturing the skin here. And now I'm reforming the canthal angle and putting a couple of 5-Vicryl sutures to ensure that the Tenzel flap's deep anchoring suture stays in the place. Muscle layer is sutured with 5-Vicryl, and the skin is sutured with, after that, 6-Vicryl. There you go. That's how he is. Thank you so much.
Thank you so much, sir. The discussion for this topic is our Dr. Chandana madam and Dr. Kasturi madam.
Nice presentation, both Joyita and Rajesh.
Thank you.
In Rajesh case, there was a dermolipoma at the lateral canthal angle, no?
No.
Huh?
That's coloboma. LaLit coloboma.
At lateral canthal angle, there is a dermolipoma. Sometimes, anyway, sometimes it is associated with dermolipoma.
Golden Haas,
also,
yes, you're right.
at
But
the
this
lateral
patient
canthal.
had a suboptimal manifestation of Chard syndrome. So he had a cardiac anomaly, he had a univentricular heart, and he had this coloboma. But interestingly, although the coloboma was quite big, as you know, Dr. Chakraborty would tell you that sometimes they do not cause any corneal problem. And this patient had been seeing me for a long time.
Not the cornea, the lateral canthal angle.
I'm saying lateral canthal angle is fine, but cornea was absolutely fine as well because the patient actually sorted out the cardiac problem first over a 2-3 years period of time and then came back for the coloboma repair.
Sometimes the defect is less. We are tempted not to do the Tenzel's flap direct suturing, but that is a bit, that should be avoided actually, because the stretching in case
Absolutely.
of children, that
Yeah.
may give away the
Absolutely.
wound later. So it is better to do the lateral canthotomy in those cases, if it is a small one. And Dr. Joita's case was a very nice case you have shown. Yes, so when the medial canthus is almost big defect in the nasally, then that procedure is a very good thing you can do. Rather than the lateral part, we are more worried about this medial part if it is. So in that case, it is a very good option to do a zugal flap.
Thank you, ma'am.
Very nice presentation, both of you. The advantage of the flap you have highlighted very well. Both of you have used a switch flap and Rajesh has used a sliding flap. A flap can always be given over graft because it has a blood supply, the color matches. A graft cannot be given over graft. However, a flap can be given between two grafts. So flap is something wonderful which has helped us in all oculoplastic surgery. Only one point to Joy, that is a beautiful surgery.
Thank you.
But whenever any tumor, like what is the biopsy of this
This
patient?
is sebaceous gland carcinoma and all the margins was free of
Yeah, so
lesion.
whenever any tumor, especially sebaceous gland, we have to do a 18 points map biopsy. That is very important.
Absolutely.
Because they have a pegythoid spread.
Yes.
And if we do not have the frozen section, then it is advisable not to go for lid sharing. So the upper lid has been shared with the lower lid. So in that case, since you are using a flap, you could have used a graft, hard pellet
At
graft.
the end of the surgery, the conjunctival flap was excised. So this is actually tarsal graft with the nasopharyngeal flap, because patient don't want any, they don't want to any second surgery. So it is single stage procedure.
Oh, you have excised
Yes,
it.
at the end I have excised
Yes.
that conjunctival.
Very nice,
stump.
because I have seen patients where the tumor from the lower lid has gone to the upper lid
Yes,
in
ma'am,
sebaceous
absolutely.
gland. So beautiful documentation, beautiful surgery.
Thank you, ma'am.
Thank you. Thank you so much.
Due to constraint of time, we are moving to the next talk. It's called Lifting the Veil. The speakers for this is Dr. Shahid Alam sir and Dr. Kasturi madam. So first, Dr. Alam sir will be speaking, followed by Dr. Kasturi madam.
So
Ma'am, if
me
you
and
can.
Dr. Kasturi will be describing two techniques that are used for management of congenital ptosis. So I'll be speaking upon the most commonly done procedure, that is tarsofrontalis sling using a silicone rod, and ma'am will be speaking about frontalis flap. Volume?
Volume ta बढ़ी दी.
To the medial. Rest of the markings are margin should be just enough to necessitate passage in on rod. All the marking sites are infiltrated with 2% xylocaine mixed with adrenaline in a 1:2 log dilution and 0.
So these are the marking sites where which are infiltrated with xylocaine and adrenaline.
0.5% bupivacaine. A stab incision is given at all the marking sites. Incision above the lid margin should be just enough to necessitate passage of the sling, not requiring any suturing.
So this is a frontalis sling.
The passing of silicone rod is started from the apex of the pentagon to the medial marking. It is then passed from the medial end to the medial lid margin incision. From the medial lid margin to lateral lid margin incision. From lateral lid margin incision
have one
to
more
lateral
minute.
brow incision. on table, aiming to keep the lid margin just at the level of superior limbus. Ostium of the frontal bone with absorbable vicryl sutures of pentagon by pulling out the rods with the help of Wright's fascia needle. The stab incisions are then closed with single sutures. Over or under correction, abnormal through the lower lid to ensure adequate lid closure when the patient sleeps and thus avoiding corneal exposure.
Thank you very much.
This suture is generally removed after 2 days. Adequate lid closure when the patient sleeps.
Just go to the end, please.
This thing. So this is on-table correction of the ptosis, and after this, a frost suture. No, ma'am. After that, there is another video. Yeah.
Okay. Thank you so much.
Thank you. Dr. Kasturi, madam.
Yeah. That was a wonderful technique shown by Dr. Shahid, and we all know that this is a very nice technique, but it has got two major drawbacks. One is the legophthalmus and second is the scar in the forehead. So these are some of my patients where we initially started doing the frontal sling, and if you look here, we do not like the scar, and also we find legophthalmus chance of exposure keratopathy. So this is what we are doing new, that instead of using a frontal sling, if we can use the own frontalis muscle, which is basically autologous tissue, and use this muscle, the power of the muscle to lift the eye, then it gives a much better correction. Advantage is there is no legophthalmus, there is no scar, and there is no chance of exposure keratopathy. We initially started with for very severe ptosis, but now we have seen that it can also be done for situation like myasthenia, for CPEO. So this is how we go ahead with the surgery, and the most important thing, you need to expose the frontalis muscle, go beyond the interdigitation of the frontalis with the orbicularis, and you expose the frontalis muscle, then this frontalis muscle needs to be pulled, and then it needs to be the suture to the tarsus. It gives a very perfect correction, and now I have almost stopped doing the sling. I feel that like this is a child sit, this is just after the procedure, and now this is the beauty of the surgery. There is no legophthalmus, and the child can close so well. This is another child where you can see very severe ptosis on the left side, and this has been done. So I have been doing this for most of the patients. This is a patient of blepharophimosis here, along with the epicantoplasty. The frontalis muscle that has been exposed, and then this frontalis muscle is being sutured to the tarsus, and you should be very careful not to disturb the orbital interdigitation of the orbicularis with the frontalis. So once you get the frontalis and you suture it, and this is what you see. See the quality of light. This is a child after 10 days. There's no forehead scar. There is no exposure keratopathy. And this is a video that he has sent me just 10 days, and see the quality of life, see the forehead, and this is how we have been doing. So with this, we have started doing more complicated cases like the Marcus gun, where after the removal of the whole of the LPS, like in the Marcus gun, you need to excise the LPS, and the same procedure that can be done, the frontalis muscle can be pulled, it needs to be identified and sutured to the tarsus, and this is a beauty you can see with the whole of the LPS being removed, and then you use the frontalis muscle, this child can close so well with no legophthalmus. So these are some of the patients even with severe condition like blepharophimosis where the same surgery has been done. And so with this, I end, and thank you very much, and requesting all of you to please bless me and support me. Thank you.
Thank you so much. That was a wonderful talk. So the discussion for this topic is Dr. Saurabh Shannal, sir.
Very nice presentation, and good morning to all of you. I have 2 points to make. One is Dr. Said's presentation. Your silicone
rod, yes,
silicone rod transfrontal sling surgery is very common and can be done by anybody. So please, if you mention the measurements, where to make these marks,
Oh.
That is very important because otherwise this will not work well. So first is that above the lid margin, 8 to 10 millimeters apart, 2 points, and then near the brow, it should be in the line of the lateral and medial canthus. And third is the uppermost incision. That should be around again 8 to 10 millimeter above the ridge, supraorbital ridge. So these forms of exact pentagon, and there the results is better. If you want to see a video of Dr. Santosh Honavar in YouTube. That is one of the best video I have seen regarding this transfrontal sling surgery. And that's I think if we remember that, it will be easier for us to perform the surgeries.
Yes, sir.
This
Actually,
measurements are very important.
Marking was there, sir, but
But where to mark?
No, it was there in the video, but in the interest of the time,
Okay.
I just forwarded
Okay.
it. Yeah.
And regarding Dr. Kasturi's presentation, this is one of the very novel technique. It is in practice now with the frontalis transposition in the lid. And previously in Marcus gun, I did some of the cases where I disinsert the total LPS and again form 3 slings and sutured it with the frontalis.
Okay, very nice.
So same procedure. You are bringing down the frontalis. I am bringing up the LPS, disinserting above, not from the tarsus. So make
Yes,
LPS as a sling.
That is a very nice thing. It's also very innovative.
Yes,
I think
we
we
have
should
done few.
also try that.
Yes, you should
And
try that.
yes.
And that if you disinsert LPS, this Marcus gun phenomenon goes.
Exactly.
And it gives a good cosmetic result. Rather than bilateral
Yes.
surgery. So
Yes.
you are bringing down the frontalis. Why not to pull up the elevator in the frontalis?
You using the strength, can you get it, Shahid? Using the strength of the frontalis, then this you use a conduit between the tarsus and
Rather
the,
than
I think we
bringing
should
down
try
the
that.
frontalis,
Yes.
bringing up the LPS with the frontalis. Bridging those two. This
Very
is,
nice.
I have done
got it.
few
Yes.
and it works well. Thank you.
Thank you, sir. We move to the third topic for the day. Dr. Shumana Chatterjee Madam and Dr. Soham Basak. Topic is coping with corneal ulcers. So first, Dr. Soham will be speaking, followed by Dr. Shumana Madam. If you can, both of you can come up to the dais. Thank you.
A very good morning, everyone.
In the interest of time, if we can kindly limit the discussion to 1 minute, please, so that we have ample time for other sessions.
So very briefly, we'll learn how to cope with corneal ulcers. I have no financial interest in this talk. So both Merriam-Webster and Collins defines coping as something like deal with an adverse situation and with a successful outcome. So as a comprehensive ophthalmologist, identify an ulcer from an inflammatory infiltrate, start empirical therapy. If you know how to do it confident, then manage. But better to refer a larger ulcer to a specialist. Timely referral is actually a good coping mechanism. So how do we cope as a corneal specialist? We have to have this armamentarium, microbiology support, compounding in the pharmacy, close follow-up and titration of medications, and also a plethora of surgical interventions. A good history taking and prior use of steroid modifies the outcome. Now, coping with patient counseling, this is probably the most difficult part of a corneal ulcer. It takes a lot of chair time. You have to reinforce the medicine and treatment compliance. Set the expectations versus reality, preferably in the very first visit. Explain about scar, failure of medical management, and long-term complications and a long drawn-out treatment. Then coping with different patients. We have to know about the organisms in a given geographical locations, urban versus rural organism distributions, a different patient profile, whether it's a farmer who is the sole breadwinner versus an IT professional who uses contact lens, a local patient versus a long-distance patient, and also talk about diabetes control. Now, coping with the outcomes. At a tertiary level, about 2/3 of your ulcers will heal with medical management alone. Rest will need some form of surgical intervention. Be mentally prepared for treatment failure. You, as a surgeon, should know that this treatment might fail. It might require a surgery. A therapeutic PK also, if you might fail and will need a secondary graft for a visual rehabilitation. So finally, don't be disheartened. Encourage your patients. More importantly, encourage yourself. Plan and time your interventions. And finally, you can cope and win. Thank you very much.
Thank you, Dr. Soham. We'll be moving ahead with the next topic. Next speaker, Dr. Shumona Madam. And thank you, Dr. Soham, for finishing well in time. Thank you.
Very good morning to everyone. And my warm thanks to Dr. Sudipta Mitro and OSWB for giving me the chance to talk on this esteemed podium. So after Shoham's excellent talk, I will show you something that is similar in presentation, the only difference being that treatment with antifungals for long had no response at all. This ulcer, this is the stained one, so which area we need to look better? This is the area. You can see a prominent peripheral guttering in this ulcer. The second case, same, not responding to topical antifungals, and you have to pay attention to this tentacle-like growth from the main ulcer. So after 3 months of treatment, you can see both the ulcers have scarred very well. So what are the magic drugs? When we have stained it, we have seen the hyphae, but you mark the difference. These have broad ribbon-like folding on itself, and these hyphae are sparsely septate or almost aseptate. So here we are dealing with the new kid in the block, Pythium insidiosum. The predisposing risk factors being same as fungus, agricultural associated injuries, and foreign bodies like dust and soil. It closely resembles fungus due to the zygomaticous branching features, but typically lacks ergosterol in its cell wall, and that is why antifungals do not work here. So what is the recommended regime? Combination of topical linezolid, 0.02%, and prepared from IV preparation directly, 1 hourly, and azithromycin eye ointment, 1% twice a day. So the typical features that distinguish it from fungal keratitis are peripheral furrowing, early limbal spread, peripheral corneal thinning with guttering and tentacular projections. So these are some more typical features given by this review article. Those interested can go through this. And thank you.
Thank you, Madam. The discussant for this topic is Dr. Somshila, Madam. Can we have a...
Thank you very much. Very good morning to everyone. Wonderful to hear both the talks. Soham, I think, gave a very good overview of coping with ulcers, but I think you meant it from the doctor's point of view. Yeah. So it's also, there's a lot of from the patient's point of view in terms of loss of their livelihood for that time and the expense of medication. And at the end of it, they expect something else. But, you know, we are very happy when it resolves medically, but they still have a corneal scar, so which is useless for vision. So we have an unhappy patient. That's why I'm coming to my talk, which is about unhappy patient. And I think your talk, in fact, dealt with one of the sort of a pseudo-fungal keratitis, which we used to think was fungal keratitis. And luckily now we know that it's not fungal keratitis. We used to always start antifungals and have a disastrous result, rapid worsening. And now that we know that it is pythium, at least in these cases, we can help in rapidly resolving the condition. So right. I think this is a very good synergy where you gave an overview from the surgeon's viewpoint and you took one particular subset of all these corneal ulcers and you discussed it. So I think this is true walking hand in hand. So thank you.
Thank you so much.
Thank you, Madam. So we have the final keynote speaker, which again is our Dr. Murthy Madam. So ma'am, can you please come up to the dais and... Ma'am will be speaking on patient satisfaction, and the discussant is Dr. Partho sir. So.
I apologize, I was supposed to load it. So often we have patients in our practice who are unhappy for various reasons. Sometimes they're unhappy because of the outcome and we didn't deliver what we were supposed to deliver. but most of the time, and watch out for these patients, they are unhappy for no reason. So the doctor is happy, but the patient is unhappy. A very good morning once again to everyone. I'm Dr. Somshila Murthy from LV Prasad in Hyderabad, and I run the cornea service there. And I'm very delighted to be part of this session and this unique kind of format for a meeting. And very grateful to Sudipta and to OS, the Society of West Bengal, and to Dr. Partha Biswas. So within the next 3 to 4 minutes or so, I'm going to just bring this concept about why doctor is happy but patient is unhappy, we don't know. So this is a 46-year-old fairly young patient who presented just before the actual start of COVID. And he also was diabetic, and to cut to the chase, he presented to us with a near total cataract in the right eye and very advanced cataract in the left eye. So everything else was fine in our cursory, in our detailed examination, so the routine, how you would have a cataract patient with you. So we went ahead and planned cataract surgery. All the parameters was normal. There was no need of putting in a toric lens or anything like that. And we performed the surgery just before COVID actually hit. And it was uncomplicated. Patient was doing well according to us. We used a Technis lens, so the patient, this is a little higher end lens in our package. And the first post-op day, vision recovery was fairly good. The fundus was normal, and by 1 week, the patient was again better. And afterwards, the patient went back home and was supposed to come for 1 month, and then there was COVID. So we did a teleconsultation, and the patient kept complaining of glares and halos with the image in his right eye. So we assumed that this could be due to some small cylindrical power, and we thought COVID would end very fast. We thought COVID will end in 1 or 2 weeks, and then we said we'll come back for glasses. So, but subsequently, of course, COVID just kept going on and on. So the patient went to our local center, which was close by, and he also subsequently underwent cataract surgery in the other eye, and he had a great result in the other eye. So in the eye that we operated at our center, he kept complaining that he had a lot of halos. So he managed to come 7 months later, and he was extremely unhappy patient with his right eye. He said he couldn't drive. He could see, continuously see a shadow in his vision in his right eye. So what he had is dysphotopsia. What is dysphotopsia? This is an undesirable optical phenomenon that occurs definitely after uncomplicated and seemingly perfect cataract surgery. There are two types, positive and negative. And the positive is that when you see something in your visual axis, maybe light streaks or some flashes or some starbursts. And negative is when you see the dark shadow in the periphery. Typically, they describe an arc-shaped shadow. Without going into details of why you have dysphotopsia, so why you could have it in our case? Was it because we didn't look at the ocular surface? Was it the pupillary size? Or was it he had some binocular disparity because he came with a total cataract and now he's able to see and therefore he has dysphotopsia? Are we missing something? So we went through the checklist, we examined the patient in great detail for all of these, and all of this was ruled out by examination. So then finally, what could we look at? Maybe the IOL. So was it decentered? Is there a tilt? And maybe there are some internal aberrations or some PCO. So when he looked very carefully between the two eyes, he was very happy with the left eye. So in the left eye, you see a very well circular rexus, but whereas in the right eye, the rexus is slightly eccentric. So this is the Technis lens which has the edge over here. And so for us, it seemed like everywhere else, the rexus was capturing the lens within it, but except in one place, where it was eccentric. So we decided that maybe if we put the haptics along the horizontal direction, and this area was no longer covered, so this problem will be taken care of. And this was the axis of the optic haptic. And so we went ahead and we did that finally. But post-operatively, we were able to manage that. The patient was not happy. He still complained of having the similar symptoms. After that, we used diluted pilocarpine for him to keep the pupil size on the constricted side. We used alpha-GAN eye drops as well to prevent pupillary dilatation. But whatever we did, the patient was still complaining of that glares and halos. So he continued to come for follow-up even recently. And off late, he says that his glares and halos have come down. Very recently also, we had a teleconsultation. He will never say that his symptoms have gone away. He says, no, I'm okay, I can drive now. But doctor, I still have the problem. And the other eye that was done locally and I paid half the money for it is perfect, but the eye that you people operated is not good. So, so what are the lessons learned? Why is this patient unhappy? Yes, he has dysphotopsia. He had dysphotopsia. Dysphotopsia can make, it can distress the patient a lot. So he was initially unhappy. He was also unhappy that the other eye result was perfect at half the price. So that was another cause for comparison and unhappiness. And all the time he really wanted us to refund the money because he wasn't happy at all. So that is up to the surgeon or the practice whether you want to refund or not. We did not refund because it was a perfect result in our case. And we felt as clinicians that his symptoms have gone away, we've addressed it. So what we can't address is what is in the patient's mind. So we have to acknowledge that the patient has a problem. There's no point getting defensive. And I learned from this case, though it was operated by my colleague, but I handled the case, that time is the best healer. And eventually the patients do get better. And don't rush in for IOL exchange when they complain of dysphotopsia, because they will get better over a period of time. So thank you very much.
Thank you, madam. Before I pass on the mic to Partha sir, we fell a little bit short on the introduction because we were running very fast for the time. So ma'am is an excellent cornea surgeon and she heads the cornea service at LVPI Hyderabad, and she's a member of scientific committee. And our Kasturi madam, who has come all the way from Guwahati, she is also a national speaker and she's very passionate about teaching, training and academics. Now I pass on to the mic to sir.
Thank you, Shagnik, and it's a wonderful day for all of us. And I just posted in the group a house full at 9:30 with an oculoplasty session. So I think it's a lot of learning for all of us and Team Scientific Committee AIOS as well. So Somshila is one of our fantastic members of Team Scientific Committee AIOS. And what Somshila presented today is something that all of us face in our daily practices. The take-home messages were excellent. One thing, if I might chip in, is unhappy patients, if you want to make them at least a little less unhappy, you have to have that trust and faith in the doctor. Refund is another factor that comes in, which shows an extreme amount of unhappiness. So time and again, you have to call the patient back. Sir, you are not having a problem is not the answer. Sir, you are having a problem. I do understand this is there. Let me try with these medicines. Let you come back again after 1 month. So calling an unhappy patient back again and again, having colleagues also re-examine that unhappy patient is the second factor. And the third factor is, actually as surgeons, we might be missing something that we have overlooked. So a colleague can find it out. And the fourth thing that a patient expects, when is the time that you would refer me to a higher center? You are not God. And that's what is in the patient's mind. And the patient will say that, do you think I should go to LVPI? Do you think I should go to Shanganitralaya? I said, of course, I will arrange everything. You go, and this is the best person. Dr. Somshila Murthy is going to see you. I fixed an appointment with you. So basically it is carrying the trust and faith of the patient from day 1 to day 100. And that is possibly one of the best things that one should do for an unhappy patient. Thank you very much.
With that, we come to the end of our first session, which was an excellent session. Beautiful learning, and I want a round of applause for all the speakers and discussions. Thank you so much. And now I request our President of OSWB to please hand over the mementos to the speakers. So please take the mementos and come. Yeah, so I call upon Dr. Shumuna Chatterjee and Dr. Shoham Bashak, who walk together. And Cornea, please come over. Please come. Circuit. Can we please have a round of applause for them? Can I just come in the picture? Yes, please. Thank you. And Dr. Joita Dash and Dr. Rajesh Mojumdar Chaudhary. Sir, please don't go. Rajesh da? Beautiful videos, both of them are very accomplished surgeons. Please come. Please, can we have some claps? Sorry. And Dr. Kasturi Bhattacharya, who has come all the way from Guwahati for this session. Thank you, ma'am. Thank you so much for coming with Dr. Muhammad Saeed Alam. Sorry that we had to stop your video, but we know your knowledge is so much. 3 minutes are just not doing it any justice. Can we have a round of applause, please? Thank you so much. And now, sir, please take your seat. We request our secretary, Dr. Debashish Das, to come over and hand over to the panelists. Okay, sir is on. Sir, you're on phone. I call upon our panelists. Discussions first. Dr. Shomshila Murthy, ma'am. Debashish, please come. Shomshila, ma'am. She is also the keynote speaker and the panelist. So can we have a loud round of applause for her? She's traveled such a lot to be here today. Thank you, ma'am. Thank you so much. We have lots of things to learn from you. Dr. Chandana Chakraborty. Debashishda, can you please continue? Dr. Chandana Chakraborty. Yes, it is done by, and let me tell you, the memento has been designed by our secretary. So, Dr. Shourabh Sharnal, sir. And Dr. Partho Biswas, sir. He is a speaker in the next session. So you want it now, sir, or later? No, please. We are honored to have. Please come. Please come. Sir is a panel. Please come. Discussion here. Sir has helped me a lot in framing this program. Thank you, sir. And can I have a photograph? I think I missed that photograph. But sir, okay, done. Okay, thank you. And I think I have not missed out in this session any one of the panelists and speakers. It's okay. And President, sir, can you please do me one more? The moderator, the young, vivacious Dr. Shagnik Shurjo, please. Yes. Thank you, Shagnik. You conducted the session very well. And can all of us please come over for a group photo? Shumona, just before you move on. Please, Chandanadi, for a group photo of this session, just to make it memorable. Please, sir, please, please, please. With the President and Secretary of OSWB. Kasturi ma'am, please. Shomshila ma'am, yes. Come, Rajesh. Shagnik. Yeah, it will be good if you can be in 2 rows, then there will be a comeback photograph. I'll come and talk. Oh, sure. Yes. Center stage. Thank you so much. So with that, we go to our next session, and I hand over to Dr. Rituparna Chatterjee to take over for the next session, which on refractive and cataract surgery. All yours, Rituparna.
Thank you, Shudipta Di. So, good morning, everyone, and let's start with one of the most interesting session of today, Walking Hand in Hand program. For this session, we have as chairperson respected Dr. Pushpita Shahu ma'am and Dr. Arup Chakraborty sir. Sir, okay. Pushpita Shahu ma'am couldn't come today, so Dr. Arup Chakraborty, please take your seat, sir. And as panelists, we have our respected doctors, Dr. Partho Biswas sir, Dr. Harshul Tak sir, Dr. Bianar Subudhi sir, Dr. Jatinder Bhalla, Dr. Nandini Ray, Dr. Arnav Mitra, Dr. Shubhra Sheel, and Dr. Smiti Rani Srivastava.
And also Dr. Anshuman Goswami. That's not there printed. Yeah.
So let's start with our topics. The first topic is tilt, pop, chop the softies. All of us will agree on the point that sometimes the softies are harder than the hardies. So we have our first speaker, Dr. Shantan, a consultant ophthalmologist at Amulo Jyoti, and he will be speaking on the nuclear management methods in soft cataract. Shantan, please.
Good morning, everyone. Thank OSWB and Dr. Sudipta Mitra especially for giving me this opportunity and podium. I'll be very fast. We tend to encounter many difficulties in hard cataracts, but soft cataracts I find are rather more demanding and difficult. The most important problem that we crops up is that there is not a proper hold or grip on the nucleus. There is cheese wiring. There are no rigid cleavage planes, so the hydrodelineation or dissection is not proper many a times. And inadequate rotating methods or cutting through the nucleus causes difficulties. So a few endocapsular techniques I'll be illustrating here. The first one is a multiplanar hydrodissection and delineation, wherein you will be seeing a very good golden ring reflex. And despite the golden ring, I go in, do hydrodelineation and dissection at multiple planes, and after that the phaco machine, the needle goes in, and the position of the phaco needle is such that it goes up to the edge of the nucleus. Using a blunt chopper with the other hand, I just try to bring in the edge of the nucleus into the phaco needle, and it comes up very easily. Herein the power is very low and aspiration is high. I go in with the epinucleus mode, and it comes in easily, caves in, and you will see that even the epinucleus at the end, fortunately for me, comes in together. So moving on to the next technique, a favorite technique for many surgeons is horizontal chopping, wherein a blunt chopper goes underneath the rhexis margin up to the equator, and it is brought in with the, from the other end, handling and holding the phaco needle at the center. And after proper separation, you aspirate in the nucleus pieces. This is the traditional way and a very good way of dealing. However, it has some problems and difficulties, especially a good learning curve for the beginners especially.
Minute to go.
Then this is the third technique that I used recently and I keep using in my cases. Mostly I form a small crater, a central crater, and go in with no power. I just sit in the center using some mechanical traction, and with the other hand I try to achieve the chop or crack. Initial first or second chops are incomplete, but the third one is quite good and it is through and through. I achieve a good chop, and after that one pole of the heminucleus is lifted up and eaten up. You will see this third one. Yes, this is the one that saves me, and after that the pole is lifted up and eaten up very comfortably. So these are some of the methods. There are many more. Some suggest that the divide and conquer technique, but due to a lack of time, I'm not illustrating it. So my take is that these patients are very demanding because they have relatively good pre-op vision. Many of them are going from for a refractive lens exchange kind of a thing. So we need to be patient, customize the technique, decide on the approach based on the situation you are in. After multiple attempts, there can be a nuclear bowl, and that has to be tackled with, which will be tackled by Basuparna. Just remember, chop, tilt or pop, whatever do you do not drop. Thank you.
Thank you, Shantanu. Thank you, Shantanu. That was a great video. Our next speaker is Dr. Basuparna Majumdar. She has done her MS from RIO and currently attached with the Boshirhat District Hospital. Basuparna, yeah.
Thank you, ma'am. Good morning, everyone present here. I feel very honored to share my work. Okay, so I'll be discussing how I usually tend to manage my soft cataracts. Let's see. So I'll directly start off with the video. Okay, so sorry for the delay. So here is a soft cataract, hydro procedures have been done, and now we are creating a small trench and trying to get a grip of the nucleus and mechanically trying to get a direct chop. But as we can see that repeated attempts are being made, but still we are failing to get a good grip and get a good chop. So a small bowl is also forming. Whatever nuclear material is coming in front of the handpiece is getting emulsified. So what we do is we try another hydro once more and try to rotate the nucleus so that we can attempt the chop from a different position. So as we will see that this will also not be a satisfactory chop. Small crack is made but not satisfactory. So now we have to directly go do a hydro and pop up a pole. That is basically lifting up the whole nucleus in the anterior chamber, applying some dispersive OVD as endothelium protective, and now we have to manage the entire nucleus in the anterior chamber itself. So keeping phaco parameters low, this can be mostly done with epinucleus mode or the phaco 3 mode, and easily the rest of the case goes on uncomplicated. So another similar video of a similar case where here already the bowel has already formed after some attempts at chopping. So simply do a hydro and lift up a pole in the AC, rotate and bring the whole nucleus in the anterior chamber, apply dispersive OVD, and the entire phaco goes on outside the bag in the AC. So from here the take home message is that first is preoperatively very important to identify the soft cataracts and ensure a proper pupil mydriasis. An adequately large rhexis is important because the nucleus has to be prolapsed into the AC. It should be just large enough to allow 360 degrees overlap of an in the bag IOL. A good cortical cleaving hydro dissection is preferred. Multi-quadrant hydro procedures may be needed.
One more minute to go.
And hydro delineation may be done, as has been shown by my previous speaker, to reduce the nucleus size to a manageable one. Nucleus management, definitely in the bag techniques are preferred, but in such cases where in the bag procedures are not possible, supracapsular techniques can be done by protecting endothelium with a dispersive OVD and keeping phaco power parameters to low to minimum in using mainly the phaco 3 or the epinucleus mode. These are my video credits, and thank you.
Thank you so much, Basubarna. That was a real good presentation. As discussants, we have Dr. Smiti Rani Srivastava and Dr. Srini Idatlan. Would you like to add something to their presentation?
I just want to say a few things. Basu and Santan both have the nice videos. Really, a soft cataract is more harder than the hard cataract. But what I'm sharing my experience, what I do, I just go for the appropriate capsular rhexis 5 to 5.5, and then hydro dissection in multi-quadrant and hydro delineation also. And then I prefer soft stop and chop technique with a long and the narrow trench. And this will help you in cracking the nucleus. You just try once long and narrow trench. This is the good one, I think. Okay, and then the main thing is that you're balancing the power and the vacuum. And what is your parameter while you are doing this?
Which case, ma'am?
Second one, the bold technique.
Second one, horizontal chop. I did not change much. I keep it in the phaco 2 around about power was say 20% or something like that, and the flow rate vacuum was around 300, 250, 300. Second case of horizontal chop, I do not change much. I change directly when I'm operating on an Infinity or a Centurion. I go into the epinucleus mode. I do not use much power. Eat up using that.
So mainly the balancing the vacuum.
Yes, yes, absolutely. The stop and chop is actually the technique I prefer, but I do not have a only video of stop and chop, direct divide and conquer I had, which I did not have much time. So,
Sayantan, it was a wonderful presentation.
Thank you, sir.
Preferably, like if you really have good control over the foot switch, I mean, you need not actually change the settings.
Absolutely.
But if you're actually teaching somebody, it might be preferable to just reduce the power.
Reduce the power.
See, that's where the surge comes, and soft, it might just cheese fire through and catch the PC. Otherwise, real nice techniques. And my preference is not to go for chopper. I mean, dialer Sinski hook is good enough for a soft cataract. Yes. And Basubarna, I mean, that's basically a bailout technique. You get a bowl and do it. You showed it nicely how to bail out if you have a bowl. But I feel that it's not really a technique that people would actually go for. but good videos. Thank you.
Thank you, sir.
Thank you so
I
much,
think,
sir.
Dr. Basupurna, why you had that bowl was because you didn't make a nice trench. So as Dr. Smita also said, if you have a nice trench in those kind of cataract, you can easily divide them.
Yes, absolutely.
And so there are only basically two techniques for softer. The very soft one which you showed, hydrodelineate, and with very low power, using vacuum and fluidics you take out. And second is stop and chop. These two things only work.
Sir, I'll have to take the hit for that. That first one was my video. I did not have a good trench. So the patient was a demanding patient, as I said.
Okay.
Multifocal patient था, तो
Thank you.
risk नहीं लेके.
I think we'll move on to our next topic. Thank you
Just
so
to
much.
add, Shayantan, when I gave him the topic, he said, Sudipta di tumi ki korecho eta keno amai dile? This is in Bengali. For Srini and Harshul, he said, why did you give me this topic? So I said, because you are an expert. Because hard cataracts have different ways to do. But you are an expert to do even soft cataracts so well. So soft cataracts, as I said, thank you so much, Shayantan, for taking up this topic. He's a prolific surgeon.
Yeah.
I'm a colleague in one of the hospitals.
Today is probably the best day of my life in profession. Madam calling me an expert. I never expected.
Oh my God, you are.
Bigger experts are here. Thank you.
Thank you. So we are moving on to our next topic, peeping through small pupil. Small pupils have always been a botheration to us. And although we have all the devices, but still they create a big problem in our life. So as first speaker, we have Dr. Shibashish Das. He is the director of Shankar Jyoti Eye Institute, and he's specializing in cataract and refractive surgery. He'll speak on hard cataract with small pupil.
With him, just Sneha also.
And walking with him is Dr. Sneha Jain, currently working as a senior resident at B.R. Singh Hospital, and she's the winner of the prestigious KP Roy Gold Medal Award. Shibashish, please start.
Good morning, everyone. I would like to thank OSWB and Sudipta Di for giving me this opportunity to speak today. So we'll be discussing on a hard cataract with intrameiosis. So, slight bit of glitch, I guess. So it was a case, it started off routinely. So in any cases, when we have when I'm staining the capsule, you see it is like a routine surgery which is going on. After staining the capsule with blue, we fill in the AC with viscoelastic and then go in with the procedure. So whenever we have a meiotic pupil or a small pupil, now a small pupil is a relative term for different surgeons. Some surgeons may find a 4 millimeter pupil small. Some may be comfortable to do a cataract through a 4 millimeter pupil also, making the rhexis to that size. So here, while doing the rhexis, we find that the pupil size starts coming down. Now, while we have an intraop condition like this, then the pupil size has come down. We have we can go through some steps. First, we will try to do it without an expanded device. Here, I see that I have still not lost the view of my rhexis margin. At any point of time, if you feel that you are not sure where your rhexis margin is going, it is always better to stop and properly visualize your rhexis margin. Here we can see when I'm filling up with visco, I can still see my rhexis margin. So I'm still safe here. I can still graze the pupillary border and complete my rhexis. But if at any point of time you are not sure that where your rhexis margin is going, it is better to stop, go in with a device and then proceed with this. Now I'll do some hydrodissection. This will also allow me to leak out some amount of viscoelastic from the AC because I'll be going in with intracameral tropicamide and phenylephrine preparation. So when the viscoelastic is out, now I go in with some intracameral mydriatic agents and inject them at the pupillary border especially. Now we see with this pharmacological use of this agent,
so we have 1 more minute to go.
Easily I have dilated the pupil, and now it is a fairly, with viscoelastic, it is a fairly good size of a pupil to work on. So we do a soft shell technique of 2 viscoelastics. And then it is a routine surgery with like a hard cataract. In these types of hard cataract, I would like to go ahead with a stop and chop technique, make a good trench in the center at first. And then we can always, once we have cracked up the posterior plate, and we get a good pieces. Getting a good chop in any hard cataract is the only way. You can go ahead with a direct chop or a stop and chop, whatever technique you are comfortable with. But cracking up that posterior plate is the thing that matters the most. So after rotating the nucleus, we'll complete the trench and they will split up the nucleus more. So you see, after making again further smaller pieces, then it's just a routine surgery where you make the pieces into smaller sizes still.
Can you go to the conclusion, please?
Yes. So to conclude, we can go ahead with the intracameral use of mydriatic agent. If that does not work, then we can go ahead with use of pupil expander devices like we have the iris hooks or B-hex ring or Malaysian ring that my next speaker will talk upon.
Thank you so much, Shibashis. That was really well managed. Over to you.
Good morning, everyone. My friend here has done a wonderful job without using any assistance, but I did require some. So this patient presented with this cataract in both the eyes. The picture on the right has a phacomorphic glaucoma. In the advanced stage, we can see the mid-dilated pupil, and I was to operate the other eye a few days after. This is also a phacomorphic glaucoma with a very shallow AC. It was difficult to make the side port. The Phenokin Plus didn't help me much. Instead, it caused the iris to come out from the side port. OVD was also of not much of an help. So I decided to stretch the pupil with the help of 2 Y hooks. The patient had IOL power of 27 diopters and the AC depth was 1.43 millimeters. Preoperatively, the patient was given IV mannitol. After stretching of pupil, I had iris coming out from both the side ports. Once the AC was formed and the iris was settled, this was the size of the pupil I had. So I decided to use a device to help me sail through this case. Created a main port, injected some OVD below the iris. I chose a Malaysian ring here as I needed a device which is flexible and strong, which could tame this sort of boggy iris in such shallow AC. Once the ring was in place, I had a good amount of pupillary dilatation, but due to shallow AC, the iris had plugged all the ports by heaping at the periphery. I was struggling to enter with the cystitome. Somehow I could manage to do so, but it was very difficult to maneuver.
We have 1 more minute to
I
go.
switched to microrhexis forceps to complete my rhexis. I went ahead with emulsification, being very careful, very gentle, as the AC was really shallow, and to make matters worse, the iris was coming out through the left side port. The cortical cleanup was again very gentle and very careful, the AC being so shallow. I had to depress the iris away from the wound before taking out and before entering into the eye. After a good cortical cleanup, being done very carefully, an IOL was inserted and the Malaysian ring was removed. This is how I ended up the case, and at 2 weeks the patient had good post-operative vision. Thank you.
Thank you, Sneha. That was really well presented. As discussants, we have Dr. Shubhra Shale and Dr. BNR Subudhi, sir. Yes, ma'am.
Very good presentation by both of you. Doing phaco in small pupil, very challenging. What I feel is when we get such a case, the decision making is very important. First, we have to see the amount of dilatation of the pupil, 4 millimeter or how much it is, and we have to judge the amount of nuclear sclerosis. So what I do is, if it is a small pupil and it is a grade 4 nucleus, like one Dr. Shivashish showed, brown cataract, and in our cases we get a lot of pseudoexfoliation cases, small pupil, we are not very confident about the zonules. So from the very beginning, start with a expanding device. And secondly, if I get cases of small pupil but the sclerosis around NS2, NS3, I'll go ahead with without any expander, use phenocane, which is very nice. And last and not the least is the softies, which we had in the previous session. If it is a small pupil and you have the soft nucleus, we'll go for just do a very good hydrodissection, delineation, float the nucleus into the pupillary plane and do the phacoemulsification. So once you can master doing phacoemulsification without any expanding devices, it's good and it's doable without any expanding devices. Thank you.
Thank you so much, ma'am. Sir, would you like to add something? Yes.
One is that in your case, don't use a pupillary expansion technique before you put the Melugian ring, especially when the pupil is already pretty floppy. So that was one reason why your iris was continuously coming out from the side ports. So don't do any pupillary expansion with your Kuglen's hooks. Do it as, once you realize that you put the pupillary dilator injection inside and it's coming out of the iris, it already means it's floppy. So it doesn't require any manual dilatation. And for you, I would suggest that always learn, or I know you know it, but always prefer to do a central direct chopping. That would be much easier because that's less traumatic for the pupil in every way possible, and the chamber is much more stable. Thank you.
Thank you so much, sir.
Can I just add one point here? Before, yeah. Dr. Shivashish very nicely demonstrated phaco in small pupil without using device. But had your pupil been, not dilating with the phenocane plus also, what would have been the preferred choice of device? Hooks, ring, Melugian ring, or BX ring?
The first choice would have been a BX ring. Then I would have, because I have access to BX and hooks.
Right.
So either a BX ring or just a 4 iris hooks. If I'm not sure of the rexis, the main thing that I usually see is that if my rexis margin that much, around 4.5 millimeter is at least visible to me. Rest I know that I can manage. But if my pupillary size becomes less than that, it is better. I prefer not to take any risk and go for an expander device than going ahead with a risky surgery and trying to do it blindly.
Very nice. Thank you.
Thank you so much, Shivashish. I think we'll move on to our next topic, keeping the plate afloat. For this, we have a very glamorous and very well-skilled cataract and refractive surgeon. She is the director of Drishtidip Eye Institute, Dr. Tanushree Chakraborty. Please start, Tanushree.
One thing that Shivashish very well mentioned, and also Sneha, is this phenocane plus, where we are in a bit of hurry or to take up our cases. Of course, those cases which would dilate, I think phenocane does an excellent job, not only dilating and also maintaining it throughout.
Yes. Walking hand in hand with Tanushree, we have our respected national faculty, Dr. Srini sir. He's the Chairman Scientific Committee of Kerala Society of Ophthalmic Surgeon, the Joint Organizing Secretary of AIOC 2023 Kochi, and he does 800 to 900 phacos every month at Comtrast Eye Hospital, Kannur and Kasaragod districts. Thank you, sir, for joining us today.
Hello, good morning, everyone.
Yes, Tanushree, you can start your presentation.
Good morning, everyone. So today's topic is, our topic is keeping the plate afloat. So we are speaking on posterior polar cataract. So whenever we have a posterior polar cataract, we have some pre-operative planning. Number one, we keep -1 to 1.5 diopter, a multi-piece IOL always as a backup, and we plan it on a day where we have a VR backup in our OT, because we have to deliver the best possible results to the patient in the same sitting. So this is my case. First, I stain the capsule with trypan blue, and I do a rhexis. The rhexis size, not too big, not too small, so that I have a fair enough sulcus if I have to place the lens in the sulcus. So around 5 millimeter rhexis is made. And after completion of the rhexis, this is a soft cataract. I do very small multi-quadrant hydrodelineation. You can see I do not over push the BSS at all. So, and we get multiple golden rings so that we can separate out the endonucleus in a nice way. Minimal rotation. Then going in with the phaco handpiece and a blunt chopper. You can take a dialer or a Sinskey hook as well. And the epinuclear plate is cleaned off. And the small endonucleus is gradually emulsified. Here, I finally rotate my endonucleus and gradually I bring it to my phaco tip and I emulsify it. Whenever I have to leave my anterior chamber, I fill it up with viscoelastic from the side port so that the anterior chamber does not collapse. And then I come off. And then I do visco dissection of the epinuclear plate. Doing visco instead of hydro dissection, obviously we don't do in posterior polar cataracts. Doing a visco dissection gives a very nice shearing force between the posterior capsule and also the epinuclear plate, like it tears off gradually. Even if we have a PCR, this is much safer as you are already tamponating the anterior vitreous phase. So there won't be any bulge of the vitreous even if there is a PCR. Here in this case, the posterior plate came off very well and rest of the epinuclear plate was taken off. And cortical wash, again when I take out the phaco probe, I give viscoelastic, come out. At every stage in a PPC, we have to do this. And giving cortical wash and single piece lens in the bag. Thank you.
Thank you. Thank you so much. That was really well presented. Next, we have Srini, sir. Our next speaker is Dr. Srini Idaklan, and he'll be speaking on no hydrophaco for PPC.
Good morning. Greetings from Kerala. I thank Dr. Sudipta and OSWB for giving this opportunity. So this is my technique for. So what I do is immediately after rhexis, I just go in with the phaco tip. No dissection at all. Just go in. If it is a nucleus that can be chopped, chop it. And I do rotate and take off the sub-chopped pieces. And you can see at the end, the posterior capsular plaque comes off with the rest of the nucleus. So as everyone advises, you make sure that the AC doesn't collapse and the intracapsular pressure doesn't go up. So you could see that pseudo hole there. Now again, so that was a NS2, NS3 case. This is a very soft cataract, do rhexis, and here you can't actually chop. So what do? You do the chip and flip. So here also, I do rotate and take off the chip flip and take off the nucleus. And you can see part of that posterior capsular plaque is remaining. If you actually polish it, you're going to get a posterior capsular end. Just tease it out, and it helps to keep the PC intact. And in this case, if you actually tighten the AC after IOL implantation, you might get a PCI. Here, you can see the pre-existing posterior capsular dehiscence there. Here also, no hydro procedures at all. Direct chip and flip. It's a very soft cataract, and so you just take it out, and you can see at the end. Here, because there is a pre-existing posterior capsular dehiscence, I do tamponade that posterior capsular dehiscence with visco before taking off the last piece. So this is something that makes it extremely safe. So do hydrodelineation, hydrodissection to make everything safer, but I don't do anything. And so contrary to the conventional teaching, I do rotate the nucleus, and it's come off really well for me. This is one more reason for me to come here, to invite you all to AOC 2023. I hope all of you have registered. We are going to, Partha sir said, you keep meeting everyone and invite everyone there here. So I'm inviting everyone. Thank you for being there. And last comment, see the very senior people show their complications so that sort of prevents us from doing something. So don't make it complicated. Dr. Kasturi said flax is the best. No need. See, I don't have a vitreoretinal surgeon backup in my OT. So this works well. So as long as you don't increase that intracapsular pressure, not the intraocular pressure, intracapsular pressure, see that weak posterior capsula is not going to give way. Thank you. Bit controversial, but maybe this is my technique.
Thank you so much, sir. So as discussants, we have Dr. Partho Bishwas, sir, and Dr. Okshuman Goswami.
It's all open for discussion, but even then, if you want to look.
So
Okay, actually, a lot has been said about the PPC, excellent surgery shown by both of you. And I do think that rotation also is feasible. You just have to be very sure that the plate does not get disturbed. And rotation can be done. It gives you a lot of leeway so that the fragments come up. And the next thing that also I do in my cases of PPC is very gentle hydrodissection, not going to the posterior pole, stopping that wave beyond the posterior pole. If one can master it, then it's not difficult at all. It can stop just before the posterior pole. You can have a very fast cortical cleanup. So it can be done, it needs to be tried, and it does not create a posterior polar rupture if it has not traversed the posterior pole.
The only issue is, it might not end up with hydrolineation. There might be a breakthrough which can actually cause an issue. See, my point here is that, see, I tried, I've recorded those videos, tried doing it with a normal cataract also, but in posterior capsular plaque, posterior polar cataract, you rotate and you see that there is a plate remaining there. Though you saw that pseudo hole there, but somehow it is there. So it's a safe technique, and we walked in hand, right?
Yeah. So let's all walk in hand to Kochi. That's the message that Srini has told us today.
Thank you, Srini. Yes, sir.
Thank you. I think Srini and Tanushree have the beautiful videos. But one comment I would like to say that the PPC is always a problem for everybody. In best of best hands also you land in complication. Don't worry about the complication. Please proceed with your case. Thank you.
The audience or the panelists can join.
Dr. Sudipta, can I add one point?
Yes, just a second, sir.
There are just 2 points I'd like to say in this. One is that one good technique, Dr. Vasavada has taught us how to do a trenching in between and doing an internal hydrodissection technique, which really works very, very well and very safe. So if it's in a cataract of grade 2, 3, and you don't expect the nucleus to come out just by flipping, this is a very nice technique of doing it. And the other thing I would suggest is that you can always use an iris repositor at times from the side ports to do a blunt dissection of the epinuclear plate from and the cortex from the anterior leaf of the capsule. That really helps in removing the whole mass of the epinucleus later on.
I think very well said, Anshuman. The technique of inside-out hydrodelineation, which you are enumerating, it works out very well. Just make a small trench, and then, because sometimes what happens is you are trying to do hydrodelineation, but inadvertently you end up doing a little bit of hydrodissection. So to avoid that, you do little bit of trench and then do inside-out hydrodelineation. That really demarcates the endonucleus, and then you can gently do. And other thing is, instead of doing hydrodissection, like Partha sir is very expert, but we may not have that kind of control where the hydrodissection stops well beyond the posterior pole. You can do viscodissection also. Viscodissection will help, and like Anshuman said, you can just take a iris repositor and just try to flip out that soft endonucleus core, and then you can, I think the slow motion phacoemulsification, inside out hydrodelineation, and be patient to avoid any posterior capsular events.
These are pearls from
Yes,
DOS
Dr. Harshad,
Cabos.
anything else? Just that's the last comment. in
Yeah,
this.
I think the key in post-polar cataract is, of course, to maintain a closed chamber. Always maintain closed chamber whenever you are taking your phacoprobe out or you are exchanging hands in irrigation aspiration. And about the capsular axis size, of course, it should not be more than 4.75 or 5, because you need to do optic capture with 3-piece IOL. If you have a larger axis, you can't do optic capture, which is needed for long-term stability of IOL. So I think these are two things which are very important.
Thank you, sir. So I think we can move on to our next topic, for miles and miles of smiles. For this, we have none other than Dr. Partho Biswas, sir. He needs no introduction, and walking hand in hand with him is Dr. Doel Biswas. She is the consultant ophthalmologist at Schustruth Eye Foundation and Research, and specializing in refractive and cataract surgery. Sir, please start.
Thank you very much. Good morning and greetings from AIOS. All of us must be in Kochi. That is the first step of walking hand in hand. Doel is going to be there, I'm going to be there, and you, all of you must be there as well. Life is like a mirror, smile, and it smiles back to you. So keratorefractive surgery and smile, latest technology, of course. The technology is ever evolving. It's purely laser-based, no flap technique, a very small corneal incision, just about 3 to 3.5 millimeters. The corneal integrity is better, more forgiving to the cornea, and almost no dry eyes. And even dry eye patients can undergo smile. So this was the idea, and it's an idea that has taken the world by the storm. 2007, and that was there in the literature. In India, we acquired SMILE, Center for Sight, in 2008. But for the last so many years, Eastern India, we did not have a SMILE. So it was only in 2021, and it was an important step for all of us in Eastern India to acquire the SMILE. But we had to learn it. And we did learn it, and we inaugurated it on the 25th of June. And it was a learning with a lot of experience. And we walked hand in hand. This is the SMILE being done, and the cap is dissected, the flap, there is no flap, and the lenticule dissection takes place just about 50 to 60 or to 70 microns. That's the lenticule pocket, and that's the cap being dissected, which is going to beyond the lenticule cut, and that is the lenticule separation that is being done under the lenticule, and this is the lenticule that is removed. So all done in about 15 to 20 minutes, and that is all SMILE is done. We inaugurated, and in August of 2022, we had live surgeries, and we had stalwarts there as well. how did Smile take on with the Eastern India? So we gradually had a large number of eyes, gradually picking up. And on 9th of September, we had 101 eyes of Smile. So knowledge is power, and knowledge is shared, is multiplied. So a huge number of surgeons, and we are really glad that the Eastern India, the Smile is being taken up, picked up, and we have all these stalwarts doing Smile, and the youngsters taking up as well. So this is the best part of the whole process of having Smile and LASIK Center in Eastern India. We did the live surgery, and thanks to OSWB, and this was a very special patient, our fellow at Trinetrale. And we did Smile on her. She had a power of 8.5 with a 1.5 diopter cylinder. But learning is incomplete without facing hurdles, and we did have our own teething problems, but we managed them. Dry spots during docking we had suction loss just after a cap cut. We could manage, and patient was 6'9" next day. We had corneal scar with vascularization. We tempered the incision, and it was done. So nothing is impossible if we go hand in hand. Thank you very much for your patient hearing.
Thank you so much, sir. Over to you, Doel. Please start your presentation.
Thank you. To say I'm walking hand in hand with the great Dr. Partho Biswas would be sacrilegious. I'll content myself with saying that I'm following in his footsteps. And yes, with all due respect, he has handheld me many a time over the last years during my refractive surgery journey. So I'm going to talk about tumble and rumble where an IPCL complication takes place. It's a very safe surgery, really. Complications are very, very rare, especially intraoperatively. The one complication that can take place is the lens tumbling. Now, the lens has a very specific alignment. As far as the ICL is concerned, there are two markings, two holes. You have to see that in the leading haptic, when you're releasing the lens, the hole is on the right, and the trailing haptic has the hole on the left. That is the simple identification for the alignment of the ICL. In the case of the IPCL, you have two holes at the junction of the haptic-optic junction. The thing is to place these two holes at the superior quadrant of the eye. So when the surgeon is sitting at the temporal side of the eye, if he's the right eye, the two holes will be on his left-hand side. If he's doing the left eye, the two holes will be on the right-hand side. It's as simple as that. But what happens if despite this, your lens still tumbles? So this is one case. This is not my case. I have borrowed it from Dr. Ayan Mohanto, where while giving the lens, it tumbled. Now, this is an ICL. It rarely tumbles, and two of the reasons why it can tumble is if you have too much of visco within the anterior chamber, or if you have air bubbles which tend to push the lens. So as you can see out here, the lens tumbles. The alignment is now lost. The vault is on the lower side downwards. So the way to solve this is very simple. You simply catch hold of the haptic-optic junction with your MacPersons and simply take it out and then reinsert it again. You have to extend the incision a little, but that will not make any difference to your overall refractive outcome. Now, that is the way to handle a tumbled lens. However, there is another way, a far riskier way, but it can also be done. The next video that I'm going to show will probably cause a corneal cataract, a corneal surgeon to have a bit of an apoplexy fit, but it has been done. I have done it more than once, and I'm still living to tell the story. So in this case, as you can see, there were a lot of air bubbles, and probably that is the reason why my lens tumbled. This is an IPCL. And as you can see, the two holes are on the lower side, lower quadrants, instead of being on the superior quadrant. So I had never had this complication before. I had never tried removing a lens. My incision was not very good and I was not very confident about removing the lens through that incision. So what I decided to do is tumble the lens within the anterior chamber. I put in a lot of visco, and I had never seen this being done either on the YouTube or anywhere else. So I was not very clear how to do it. I tried doing it with a single instrument, pushing it, but I was unsuccessful. That's when I went in with 2 instruments, and with a bit of a struggle, since I was doing it for the very first time, I did manage to flip the lens. I have attempted this once more. The second time, of course, I was wiser. I went in with a lot of visco and 2 instruments at the first go, and I was able to tumble it very easily. And as you can see, now the 2 holes are in the superior quadrant and it's in place. As I said, the tumbling of the lens within the anterior chamber is not the way to go, especially for beginners. However, if you have any problem removing the lens, and I've had a problem more than once, the second time I tried to remove the lens, my MacPherson just kept slipping and I found it easier to tumble the lens. You can tumble the lens provided you put in a lot of visco to safeguard the cornea above and the physiological lens below. In that case, it is very easy to tumble these lenses and put them back into place. My vision was quite good. The first case, I had a wee bit of corneal edema at the periphery. My second case, where I was more careful, I barely had any corneal edema, and my specular did not show much of a loss of cells. Thank you.
Thank you so much, Doyle. That was really well presented, as usual. Over to you, Dr. Harshul Tak.
Yeah, thank you
like
so
to
much.
discuss some?
So, very nice videos, Dr. Doyle. I think the biggest trick which I learned over the years for ICL doesn't open up in a funny manner is the 3 holes which are there in the center of the ICL. So when the ICL is unfolding, always keep an eye on those 3 holes. They should be in straight line. If it's opening like this, you turn your hand here. If they're opening like this, turn your hand here, and slowly keep pushing it. You'll never have situation like this. But it happens in initial years with everybody. And of course, as you said, we should never try to, just tumble it in the anterior chamber, especially if the ACD is less. If it's ACD is deeper, okay, you can take chances. But it's always advisable to pull it out. It's very easy. It comes out through the same 3.2 mm incision. ICL comes out and you can again reload it. And I think no comments for Chairman Scientific Committee, Dr. Partha sir. Whatever he says, he's right.
One of the biggest ICL leaders.
Thank you so much, sir.
So I think Harshul, you have to invite on behalf of ARC to Kochi, right?
Yes, of course. I take pleasure in inviting all of you for AIOC 2023 for all to attend all the ARC programs which are there on the first day, and of course to attend a grand LBO evening on Saturday night. Thank you. That he'll invite.
The scientific committee has had to sacrifice its program for ARC. Thank you very much.
Thank you so much, sir.
Anybody from the audience wants to add anything about refractive surgeons from the audience or the panelists? Yes.
Just to highlight that, Doyle, I think wonderful video, but just same what Harshul said, that we should not go with the message that we can tumble it in AC. That should be the last option. And
no, ma'am, it
especially
is
as you
the
said,
last option.
No, you cleared that, yeah. Just to mention that when it's IPCL, you have a spare lens. So if the MacPherson doesn't work, and it often doesn't, in fact, we have some disastrous MacPhersons which cross like this. So it doesn't hold the lens, and the lens is very slippery. So what I often do is if I have a very slender limbs, which we have because we do our cornea transplants, so you can, with the limbs, you have to be very careful, of course. You can pull out the lens very easily because it bites into the lens. And you always have the standby lens. So I'd rather sacrifice the lens than try to tumble it. But in ICL, you can't do that because you don't have any spare lens. You can't damage the lens. So in ICL, still you can extend. And ICL is easier to pull out. It comes out very nicely because it's usually not that long. Somehow the configuration is easier. It's amenable to pulling it out very nice. It just slips out as you showed. So for ICL, you should try to pull it out. And IPCL, we don't mind too much if we damage it. We have a spare.
In the IPCL, what I found when I was trying to pull out my second lens is that the lens was so big, the usually the lenses, the diameter is so big, it sort of sometimes folds the haptic part, and that's when it becomes very difficult to hold at the haptic-optic junction, especially with a Mac person.
These were very nice discussion for people who are learning phakic IOLs. And in interest of time, we go on because these discussions can again go on over our lunch. We have Dr. Pradeep Mahanto, sir, was supposed to speak, but because of a mishap at home, he has not been able to make it today. Instead of that, we'll have Dr.
Stopgap arrangement?
No, sir, it's not that. It's also because your flight is
Thank
early,
you.
so
Thank you.
Dr. Diana Subodhi, sir.
So it's out-of-box topic. Thank
So
you.
let us just introduce you. As a keynote presenter, we have Dr. BNR Subodhi, sir, and he's the chairman of Ruby Eye Hospital, Berhampur, Orissa. He's a retired head of the Department of Medical College, Berhampur, and he's a secretary of Teleoptha Society of India. Sir, you may start.
Thank you. Thank you for giving the opportunity to speak before you. So this is actually, as I told you, some serious topic was going on. Suddenly I was called to speak on something community topic. Of course, true. We were always, more than 2 hours we were discussing only for urban people only. What about the community who are suffering? How we are, what is our approach? So, thank you, Sudipta, and thank you, the Hands in Hand program by WSB. Really, I thank all of you to invite me to this forum. So everybody knows, I don't want to discuss much about the prevalence of diabetic retinopathy. It's one of the most important ocular morbidity in India, and it has increased so mostly post-COVID era. And many times we've seen that screening and awareness at the back foot. So that's why we have to screen all the people for diabetic retinopathy, particularly in the community, in the rural areas. So fundus imaging using artificial intelligence is the need of the hour, and incorporate teleophthalmology, these two things definitely help in progressing to the check the diabetic retinopathy program. Diabetic retinopathy threat. So early detection of diabetic retinopathy, why should we do the screening? To detect the early detection of diabetic retinopathy, and early intervention is the most cost-effective choice. And why screening? Screening is also very important because retinopathy is a guide for the diagnosis and management of other systemic complications like retinopathy, nephropathy, neuropathy, and cardiopathy. So by diagnosing diabetic retinopathy, probably we can halt these three also simultaneously. Awareness, we have seen a lot of news that has come that the public, particularly rural public, is not aware of the diabetic complications which may lead to blindness. So we have to create awareness too in the rural areas. So what are the challenges? As you know, we have got a shortage of doctors. We are only 20,000 ophthalmologists and a huge population of more than 140 crores. And definitely the inadequate infrastructure in the rural areas is another factor which is responsible for our backstage of the diabetic retinopathy screening. So here we come, the teleophthalmology of India. So eye care access through teleophthalmology. India is full of this type of areas. India is a diverse country, and we got all these areas where we are not able to reach, and they are mostly unreachable. As we are not able to reach, so the technology also has not reached them. So can you take this technology to them? Yes, we can. So only by teleophthalmology only. So we can use the smartphones and some portable devices where you can take the serial photographs, and you can utilize the trained health workers who are working in the rural areas. Sometimes paramedics can be utilized to take these photographs and transfer the images to the people sitting in the urban areas for the integration. So this is the teleophthalmology concept, a mobile van with all these equipments go to the rural areas where they screen the people for diabetic retinopathy, and they send the images by digital technology to the higher centers for the integration. So screening, already a lot of portable cameras available in the market. So we must avail any of these cameras and we can do screening. Not only our diabetic specialist and not only the retina specialist, all of us, even your cataract specialist also, you should do help in this our program. So thus teleophthalmology services can be utilized for the door-to-door screening too. So use of automated DR image assessment with incorporate AI can take the images and it can also tell us which case is referable and which case is not referable. So this is the screening module. Arrange a diabetic retinopathy camp, go with the camera with
So
AI.
1 minute to go, sir.
Incorporate AI with that, and probably we can do the screening of the people. So now, recently, we have new additions like artificial intelligence, 5G, and metaverse. So these are the three new additions which can help us in achieving our success. So teleophthalmology with AI, 5G technology, everybody knows about 5G technology, how fast it is, transmit the data, and of course, metaverse is establishing virtual clinics in the rural areas. So this is the teleophthalmology in the future. We can think that there is an ATM machine, just like the bank machines. This machine can be incorporated in the railway stations. It can be airports where the patient goes. Any patient, an elderly person goes and takes photographs. And this photograph automatically integrated by the people sitting in the remote areas or the rural, urban areas. They can immediately tell us whether this patient needs referral, or patient not requires referral. So that at least this way we can check our diabetic blindness. So teleophthalmology artificial intelligence can show us the way eye care can reach every village of India. So this is the 2C, that's the Teleophthalmology Society of India. I am the secretary of the Teleophthalmology Society and Dr. Natarajan, the president. I invite all of you to become a member of the society and be a part of our movement. So our aim is to beat diabetic blindness by screening all diabetes in our country. Thank you. Last but not the least, I have come all the way to appeal to you, all IJAC members sitting here. Please help me achieving this success. I am contesting for the post of editor proceedings in the AIOC elections. Only 2 months left. It's mostly digital only. So please update your profile and help me. Thank you very much.
Thank you very much, sir. For discussion, we have Dr. Jatinder Bhalla and Dr. Anshuman Goswami.
Sir, appeals to all the AIOS members here.
Sorry?
He said IZOC, so also AIOS members.
Yes, absolutely. Of course, true.
I think very nice talk, Dr. Subudhi sir. It's a need of the hour. Teleophthalmology is need of the hour. I was discussing with sir that screening is important, but what happens is once the patient is diagnosed, it depends on the literacy level, the consciousness level, and how seriously is he taking his visual problems. Most of the time what happens is diabetics they just are concentrating on getting their blood sugar controlled. Even the physicians generally, they just tell them casually that you have to get your ophthalmic checkup done. If we have a one is teleophthalmology definitely which goes to the remote corners, and secondly is having consolidated diabetic clinics where not only the physicians, endocrinologists, even ophthalmologists is part of that team where the screening is done there and then. And another need of the hour suggested by sir is that what we should have is low cost, make in India OCTs which can there and then diagnose whether there is diabetic macular edema or not. I think we have long way to go, but if these things are taken into consideration, I think it will be a great help, great boon to our diabetes.
Whether you are a cataract surgeon, whether the oculoplasty surgeon, or a glaucoma surgeon, everybody comes across a diabetic patient. So you insist on take a retinal photograph. That's the most important.
That is the most important thing.
Right.
Very nicely presented.
Thank you.
Any comments from the audience? Any comments from any of the panelists? Okay, sir. Thank you so much. That was a very enlightening session, teleophthalmology. With this, we come to the end of this session of refractive and cataract surgery. And I would request our ex-president, sir, Dr. Kajal Prasad Ghosh, sir, to come and hand over the memento to our chairperson, Dr. Arup Chakraborty, sir. Please, memento. Arup, we didn't hear a comment from you about this session also.
Thank you, Sudipta. I did nothing, but I am getting the medal. So anyway, excellent meeting, excellent presentation, and especially the juniors. They are excellent surgeons, and I have been seeing their videos. Experts' comments from the panelists also. So nothing to say. Thank you, Sudipta. Thanks very much.
So, memento. Stay there. For a photograph. Can we have a round of applause for? Thank you, sir. And so be seated. Request our Where is our Joint Secretary, Dr. Shugato Pal? Please come over to hand over the mementos to our panelists. Dr. Anomitra sir has left, so Dr. Shubhra Sheel, ma'am. Dr. Shubhra Sheel, ma'am, she's also left. Oh my God. Dr. Smriti Rani Srivastav. No, Smriti Rani. Can we have a round of applause? Memento, by the way. It's here only, na? Smriti Dir. Here. Come over. Please stand here. Keep the windows down. Yeah, and Dr. Bhalla, Dr. Jatindar Bhalla, please come, sir. You're also a panelist in this session, although you're a speaker in another. Dr. B.N.R. Subudhi, sir. Dr. Harshul Duck. Dr. Harshul Duck. Yes, sir. Yes, sir. Just. And Dr. Partha Bishwas, I said we handed over earlier, no? Sir, we handed over the memento to you already. Okay. Now we request our ex-secretary, Dr. Shubhashish Nag sir, to please come over to hand over the memento to our speakers, Dr. Bashuparna Mojumdar and Dr. Shantan Bhattacharya. Dr. Shantan. Bashuparna, please come over. Shantan must have gone out. Dr. Shibashish Dash and Dr. Sneha Jain. Yeah, please take a photograph. And can we have a round of applause for this? Yes, Shantan, come over. You're here. Come, stay back. You both walk together. Come. Run. Shantan has come.
Sorry, sir.
Yes. Dr. Sneha Jain and Shibashish Dash. Please wait, all of you. We'll have a group photograph at the end. Sneha, please come. Hand over. Sneha, wait a minute. Dr. Tanushri and Dr. Srini. Dr. Srini, I think he was outside. Shagni, can you just call Srini's outside? Tanushri, please come. Dr. Doel Biswas. Dr. Doel. Parthoda, can you just come and stand for a while? Because she was walking here in the refractive surgery session. So for a photograph. Yeah, Doel. Yes. That showed today also. And that's all. Dr. Srini is waiting. We want a group photograph of the session. So please, all the participants, panelists, chairpersons, please come over. Also, the Dr. Angshuman Goswami. Dr. Angshuman Goswami. Please, দেখো পেয়েছো দুটো মিসিং ছিল সেটার মধ্যে এটা নয় তো ঋতুপর্ণা তো ডেফিনেটলি থাকবে গড ওকে একটা নিয়ে চলে এসো ছবিটার জন্য পরে হ্যাঁ দিয়ে দাও জাস্ট আ সেকেন্ড ইয়া প্লিজ তোমার আছে একটা দিয়ে দাও এটা নিয়ে একটু দাঁড়াও তোমার নামটা আসেনি ছবির হ্যান্ডিং ওভার দিস নামটা টিকে দিন নামটা সামনে পড়ে যাচ্ছে সামনে চলে এসো অংশমানি the other yeah, you have to join. It will be in the group, sir. It will be in the group. We've got a WhatsApp group, so we get it in the group. Okay, sir. Whatever. Srini, where's Dr. Srini? Oh, she's not there? Thank you so much. And with this, we come to the end of this session. And next is our glaucoma session. And Dr. Shohini Ghosh. Dr. Shohini Ghosh. Oh, so I hand over the I hand over the mic to Dr. Shohini Ghosh to carry on with this session.
Thank you so much, Dr. Sudipta. Yeah, a very good morning to all of you and to this vibrant galaxy of eminent ophthalmologists. I'm sure with our best of the panelists and best of the speakers, we are going to have a truly learning session today. And we all are hoping to find the light at the end of the tunnel vision. So we start with our glaucoma session. It gives me immense pleasure to introduce our chairpersons for the session. May I please welcome Dr. Parag Mukherjee, sir, our past president, a prolific surgeon, and he's achieving all the changes in ophthalmic and medical practice. Dr. Suchitra Majumdar, ma'am. Good evening, ma'am. She's a great academician, a teacher, serving in West Bengal Medical Educational Services, and a great anterior segment surgeon. Welcome, ma'am. Please come and sit here, ma'am. And it's an honor and pleasure to introduce our panelists for the session. We have Dr. Niloy Majumdar, sir. Good morning, sir. And he's a senior glaucoma consultant in Sushrut Eye Foundation and Research Center. We have our very own Dr. Shubhashish Nag, sir. Morning, sir. Who's an expert anterior segment surgeon with keen interest in glaucoma. He's practicing for over 3 decades in Oculus Eye Clinic in central Kolkata, and he has been our honorary secretary for 3 terms and honorary treasurer for 2 terms in OSWB, and of course organizing secretary of AIOC 2024. Next we have Dr. Moitri Das, ma'am. Morning, ma'am. Ma'am is an accomplished glaucoma specialist, and she has always reached out the masses with her philanthropic community service project, and she has received many awards for her dedication in service. And next we have Dr. Tutul Chakraborty, ma'am. She's an expert glaucoma specialist. In 2019-2020, she was awarded the Fulbright Nehru Academic Award at Hamilton Glaucoma Center in the University of California. Prior to it, she was awarded the DST grant from the Government of India as principal investigator for her project. She has more than 20 publications as the first-hand corresponding author in the index journals, and her recent paper has been selected as the paper of the month by advisory board in World Glaucoma Association. Welcome, ma'am. Ma'am, please come here. And last but not the least, we have Dr. Tulika Ghoshal. Ma'am, please. And she is an comprehensive ophthalmologist and a visiting faculty at KPC Medical College Hospital. She has a rich experience in for over 25 years seeing patients nationally and internationally. Please, ma'am. And it's a great honor to introduce our first 2 speakers. They have already walked hand in hand. We have Dr. Harshul Tak and Dr. Nasneem Nadam. They will be speaking on the lens-induced glaucoma. Dr. Harshul Tak is a prominent comprehensive ophthalmologist who has held very important posts in AIOS and Rajasthan Ophthalmic Society, and he has also many awards and accolades to his attribute. And he is the pioneer of popularizing life beyond ophthalmology all over India. Warm welcome, sir. Sir, please start your session, sir. Yes.
Thank you so much, Dr. Sohini, and first of all, warm regards to all OSWB members. I also take pride in being a member of OSWB. I became member 4 years back. And thanks, Dr. Sudipta, for giving opportunity to be a part of this program. Can I have my presentation, please? So we all know that lens-induced glaucoma, there are various challenges in dealing with these kind of cases because there is raised IOP because of either a phacomorphic or a phacolytic glaucoma because of the lens. So I'll be sharing two videos quickly with you. So first, we all know that we need to control the IOP before we take up these cases for surgery by giving mannitol for 2 to 3 days. And once the pressures is controlled, then we can choose the surgery which you are skilled and comfortable with. So my choice is always phaco in these kind of cases. And this is another important advantage and use of Phenocan Plus. Many times we see that if we dilate these patients 2-3 hours back, IOP again increases, cornea become edematous because of raised IOP. So I stopped dilating these patients preoperatively. I just dilate them on table so that we don't get any chances of developing raised IOP. So here goes the side port incision and then the Phenocan Plus. And once the Phenocan Plus is put, and I love to do them under topical anesthesia only, because what I feel is retrobulbar or this block again increases the pressures behind. So once you have made the side port, put the Phenocan Plus and stain the anterior capsule, you see it achieves the dilatation which is needed. And it was a slightly deep set eyes. So again goes, so the next challenge is to create capsulorhexis in these kind of cases because there is raised intracapsular pressure. So a sequential two-stage rhexis is what I described in 2010 in ESCRS and what I've been teaching for years. Make a very small rhexis in center. You see the liquefied cortical matter comes out. Go ahead and use microforceps because this central area is the safest area where we can make capsulorhexis. And once you have made small capsulorhexis like this, go with 27 gauge cannula and see the amount of liquefied cortical matter which is coming. And it's important that you don't only debulk from main port, go from side ports also because these fluid filled pockets are everywhere. So go from side ports also, debulk the capsular bag all around. And once you have debulked like this, then you can go ahead and give a small cut there with micro scissors and make a capsulorhexis of adequate size. As you can see, this size, rhexis size is perfect. Most of these cases are brittle. There's nothing great in chopping them, but you should try to do direct chop. And once you have these pieces out, go ahead and put a IOL in the capsular bag as a routine case. So this finishes the case. Another situation which we can have is Morgagnonian cataract in cases of phacolytic glaucoma. So problem here is not of raised intracapsular pressure, but problem here is the liquefied matter. Once it comes off, the capsule is very friable and zonules are weak, so you need to be careful. And lens is mobile there. As you can see, it's rotating. There is no cortical cushion there. So chopping them is a tricky part. So horizontal chopping works best in these cases. Go ahead, hold them in center and get your chopper from equator. Pull it up towards you. And once you have divided it into smaller pieces, as you can see here, the entire nucleus goes off and you have nice and clean case. So I think if you use the right technique and right tools, you can get away with these kind of phacomorphic, phacolytic glaucoma also safely with phaco. Thank you very much. And now over to Dr. Nazneen for her cases.
Well, Dr. Nazneen is an associate professor in ophthalmology, ESI Medical College, Joka, and she has keen interest in glaucoma and neuro-opthal. Over to you, Dr. Nazneen.
So, good morning. Lens-induced glaucoma topic just as vast as my co-speaker's experience. However, to cut a long story short, lens-induced glaucomas are usually secondary glaucomas, most commonly associated with cataractous lens. And again, the glaucoma can be open angle or angle closure. The two most common type of glaucoma in this category are phacolytic glaucoma and phacomorphic glaucoma. Phacolytic glaucoma we know is associated with a hypermature or Morgagnonian cataract. Patient presents with pain, redness, diminution of vision, along with very high IOP and open angle glaucoma. The eye is usually inflamed as well. So this is an emergency, it needs to be tackled very fast. Steroids are needed to be given preoperatively and also postoperatively to reduce the inflammation. IOP reducing agents to control the intraocular pressure, and the definitive management is cataract extraction. Phacomorphic glaucoma usually associated with senile mature cataract, which causes a pupillary block, and this blocks the aqueous humor outflow. The presentation is similar to acute angle closure glaucoma along with mature cataract. Patient presents with severe eye pain, headache, corneal edema, shallow anterior chamber, mid-dilated pupil, high IOP. The treatment is anti-glaucoma medications. Some advocate a YAG laser PI, some go ahead straight away with cataract surgery. The definitive management again is cataract extraction. So some important points are, it is very important to control the intraocular pressure preoperatively, do a gonioscopy and look for optic disc cupping. Give preoperative mannitol on the day of surgery. Intraoperatively, visibility may be an issue because of the corneal edema and the inflammation. Do a 2-stage CCC, and in the postoperative period, expect a lot of edema and inflammation. In some cases, trabeculectomy may be required if there is advanced glaucomatous cupping and uncontrolled IOP. So I have just a video to demonstrate, and thank you, Dr. Harshul, for sharing your video with me. So this case was phacomorphic done in topical. So you stain as usual and do a 2-stage CCC. That is, you make a small CCC and then go ahead with the microrhexis forceps and extend your capsulorhexis. The rest of the steps are more or less the same. So once you make a small CCC in the center, you can extend it with your microrhexis forceps. A little bit of hydration to reduce the intralenticular pressure. Then extend, make a cut and then enlarge your capsulorhexis.
Nazneen, I think if you could just fast forward your video a little bit, please.
The remaining steps are the same as phaco. It's routine.
Thank you.
Thank you.
Thank you. Thank you so much. It was a very crisp and to the point presentation. May I request our discussants, Dr. Shubhashish Nag sir and Dr. Srini sir, if they want to add something.
I think the videos were excellent and self-explanatory, and the topics Nazneen, of course, showed all the forms of lens-induced glaucoma, but the two most common are the phacolytic and the Morgagnian one. I think the key point was the 2-stage rhexis, the intralenticular pressure. The Argentinian sign dikhaya nahi Harshul ne. He has, I think, he doesn't have any videos maybe, but we all have faced that situation. So the intralenticular pressure has to be managed so that it doesn't go up. You do that by, people have got ways, you do that by sucking out a little of the fluid, initial,
yes. So,
thoda sa prick karke.
In that case, if you try to suck it with the 26 gauge needle, the margins are irregular. So where you have irregular margin, it can give way any time. So if your intention is to make a curvilinear cut and to make a small rhexis, believe me,
it doesn't.
For years, yeah, it works.
Great.
And it's fine. If in 1% case it doesn't work, then you don't have any choice than to continue.
Yeah, that's it.
But
and
you should
use of this micro forceps thing.
Yeah,
that one has to master.
Yes. So you need to go through side ports also, because the direction of pull has to be perfect.
Right.
Yeah.
So that was fine.
And moreover, I felt that using intracameral phenocane plus not dilating them, it also helps.
Phenocane is a very good blessing.
So I'm coming to our next topic of discussion is glaucoma affecting the vascular systems. May I request Dr. Shutapa Roy and Dr. Alokesh Ganguly to take the dais. Dr. Shutapa Roy is a consultant cataract and glaucoma surgeon, and she's an assistant professor in Shishu Mongol Hospital. And Dr. Alokesh Ganguly is a prominent ophthalmologist and glaucoma specialist, and he is practicing in Priyambada Birla Arvind Eye Hospital. Welcome, doctors.
OSWB, thank you OSWB and Sudip Tadi for giving me this opportunity to present a case of RVO and PACD. This was a 56-year-old female. On presentation in December, she had base corrected visual acuity was 6.9 in both eyes, and fundus and anterior segment examination was more or less normal. But within 1 month, she presented to us with sudden dimness of vision for last 10 days, and her visual acuity came down to FC 1 fit, and there was inferior hemi-CR view in the left eye. IOP was examined in dilated condition, and it was 48 in the left eye. So patient was advised brimonidine timolol combination along with oral acetazolamide and come for follow-up with blood sugar, lipid profile, and OCT macular reports. This was her fundus finding and OCT finding. When she came back after 7 days, we did slit lamp examination meticulously, and there was no neovascularization, but in Van Herrick's grading, the angle was definitely, Van Herrick's grading, AC was definitely shallow in both the eyes, and on gonioscopy, right eye was open only up to anterior trabecular meshwork, and left eye was open up to Swalb's line only. This time, IOP was normal, and she was found to have blood sugar level high, and YAG PI was advised in both eyes. So this was a case of angle closure disease in a retinal vein occlusion. So is there a role of angle closure in the development of RVO? Yes, coexistence is 33%. Incidence of glaucoma in CRVO is 41% and BRVO 27%. And primary angle closure is more in RVO with diabetes and coronary artery disease. These associations first reported by Varhoff and Here et al. Also. They said that PSC and PSCG induces RVO through a mechanism similar to POAG by a compressive mechanism on the lamina cribrosa of the optic nerve, and CRVO is more common than BRVO. In different articles, they have also found this association. In Chinese population also, they have found the increased frequency in these RVO patients. PSC and PSCG frequency is higher. And this was a recent study in North Indian population by Sunita Dubey et al. They have also found that it is an independent risk factor for development of RVO and should be kept in mind for all patients with RVO. So my take-home message is association of PSCD and RVO is less known, but it can be a risk factor for RVO, and comprehensive eye examination and detailed angle evaluation should be done in all cases with RVO. Thank you.
Thank you so much, Dr. Sudipta. It was a wonderful presentation. Over to Dr. Alokesh Ganguly.
A very good morning to all. I'd be speaking on how vascular systems affect glaucoma and other case presentation. In contrarian viewpoint to what my earlier presenter has presented, where there is affection of the vascular systems with blockage of the arteries and veins, we are talking here of the patient vascular systems in a case. Post-operative, a 68-year-old male who presents with a sudden onset of seeing black shade in the right eye, 2 weeks duration. There was a history of undergone combined surgery with IOL implantation 5 years ago elsewhere. The left eye was on latanoprost. These were the systemic associations of the patient. On clinical examination, we found that the bleb was low and diffuse, but it was filtering. The best corrected visual acuity was 612, a patent PI with pseudophakia. Sedals negative, no leak from left side, but a GAT of 0.4. Carefully done gonioscopy in a soft eye showed no cyclodialysis and patent PI, left eye was open angles. So when we examined the fundus, as you can see here on the right side, there was a choroidal detachment. And the USG confirmed a 360 degrees peripheral CD with no choroidal mass lesion seen. The retina was attached, no T sign. So we searched the literature, and we found that there are 2 case reports of post-trabeculectomy choroidal detachment 5 and 7 years after surgery. So we diagnosed it as a late onset choroidal detachment after combined surgery and treated with steroids and cycloplegics. 3 weeks later, the patient came back. The systems had worsened. Rest of the findings were status quo, but the GAT was almost unrecordable at 0.2 and nearly kissing choroidal detachments. Again, we go back to the literature. Case report of choroidal detachment associated with latanoprost use in the fellow eye. And as mentioned earlier, this patient was taking latanoprost in the left eye. As we can see, the left eye does not have that much of a damage. The disc looks more or less normal. We stopped the latanoprost and continued with the treatment. After 2 weeks, the patient reported improvement in his visual quality, and the GAT was recorded as 0.8. The second USG follow-up, the fundus picture showed resolving kissing choroidals, and this actually fully resolved. So the points to ponder. Though mostly an acute complication, choroidal detachment can happen years after the trabeculectomy surgeries. Anti-glaucoma medications used in the other eye can potentiate such choroidal detachments either through IOP reduction by vascular transfer of absorbed drug in the other eye, or perhaps some other unknown mechanisms. Thank you.
Thank you so much, Doctor, for bringing so many points on discussion. May I request our discussant, Dr. Nilay Majumdar sir, to add on his views.
Thank you. Wonderful cases and wonderful discussion. First about Dr. Alokesh's case, I myself met a case of such choroidal detachment, late choroidal detachment, maybe 3 to 4 months after I did the phaco-trap surgery in that eye. The patient had systemic complications. The patient was under dialysis for a kidney problem. So that thing might play a role in that choroidal detachment. I don't know, maybe some vascular phenomenon is occurring, but everything else was okay. And regarding the presentation by Dr. Shudapa, increased IOP is definitely a risk factor for RVO, especially if it is more than 30. We should always treat those cases, and probably while the patients come for routine checkup, we should at least do the vanity at the beginning to see whether the angle is narrow or not, so that we cannot miss angle closure in the early stage. Thank you.
Thank you so much, doctors. Moving on to our next topic of discussion, may I request Dr. Tania Bhadro Roy ma'am and Dr. Sabyasachi Patnaik, who would be discussing on secondary glaucoma revisited. Dr. Sabyasachi Patnaik is working as an additional director health services. He's a senior consultant ophthalmologist, and he's trained at Arvind Eye Hospital, Madurai, LV Prasad Institute, Hyderabad. He's a Commonwealth Fellowship on Diabetic Retinopathy, International Center for Eye Health, London, and he has received many awards at state and national level. Welcome you, sir. Dr. Tania Roy Bhadra, she is an assistant professor in Medical College, Kolkata, and a prominent glaucoma surgeon. Welcome you, ma'am.
Everybody. So at the outset, I thank Dr. Sudipta and OSWB for giving me this opportunity to interact with you in this special morning. So what we have been assigned to discuss is secondary glaucoma revisited. Me and Tania, I think we are going to do justice to this topic. So secondary glaucomas, as you know, is a group of disorders in which the increased IOP is associated with some identifiable primary ocular or systemic disease. So they are also divided as open angle and angle closure glaucomas. Then open angle glaucomas, the underlying pathological mechanism lies in the trabecular meshwork, maybe trabeculitis or obstruction of the trabecular spaces by cellular material, extracellular materials, changes in the metabolic activity of the trabecular meshwork, and increase in episcleral venous pressure. And angle closure may be synechial or non-synechial. With this brief introduction about secondary glaucoma, we are going to present pigmentary glaucoma or pseudo-exfoliation glaucoma. Patient 65-year-old male with complaints of painless gradual loss of vision for last 3 months. History, there was no other systemic illness, patient is healthy, not on any medication, no family history of glaucoma. So these are the pictures we are most familiar with in dealing day-to-day practice. Pseudo-exfoliation material in the lens entry capsule, and on gonioscopy we can see that the pigment or materials deposited in the angle. So in examination is best corrected visual acuity in right eye is 660 and left eye counting finger 3 meter. Pupil, right eye normal, left eye there is ROPD. IOP is high in the left eye. So retina almost normal, optic nerve, complete cupping in left eye with field effects. So pseudoexfoliation glaucomas are mostly in early stages are asymptomatic. In later cases, there is loss
So
of
we have
peripheral
a minute
vision,
to go.
as in POAG. So signs mostly bilateral, but often can be unilateral also with asymmetry. So treatment mostly as POAG in initial stages. So the IOP has to be maintained well controlled, and then in spite of maximum medical therapy, if it doesn't control, then we can think of laser trabeculoplasty or filtering surgery. That will be taken care of by Dr. Tania. So my patient was well controlled with topical medications. We have to differentiate from other unilateral glaucomas in these cases. So to conclude, secondary glaucomas differ from primary by the fact that if the primary pathology is treated properly and the possibility of secondary glaucoma is kept in mind, the glaucomatous damage can be easily prevented and blindness can be avoided. Thank you. Thank you very much.
Thank you so much, Doctor. Over to you, Dr. Tania.
So, very good afternoon, and thanks to OSWB for giving me this wonderful opportunity. Today my topic is on periloid pigments. Listen to learn. Present illness, a 56-year-old female came in our OPD, diagnosed case of primary open-angle glaucoma with a complaint of dimness of vision in both eye and right eye more than left eye. Personal history, the patient was a non-diabetic, non-hypertensive and high myopic, and patient was on multiple anti-glaucoma medication for the last 2 years. General physical examination and the systemic examination was normal. On ocular examination, the right eye visual acuity 4/60 and the left eye 6/60 and the PRE inaccurate. And the IOP in right eye 40 mm of HE and the left eye 16 mm of HE. This is the slit lamp examination, shows the Krukenbach spindle, both eye. And this is a gonioscopic finding, homogeneous patchy pigmentation seen over the trabecular meshworks and the angle open. And cupping in right eye was a total cupping and the left eye 0.8:1. And HFA findings right eye, there is an advanced field damage and macular threshold study was done and that shows the macular split. And the left eye also advanced glaucoma, but there is no macular split. And this is the USG-B scan, showed the both eye. There is a posterior bowing of the iris. So the provisional diagnosis pigmentary glaucoma in the both eye with a macular split in right eye. This is very challenging case. So the treatment, after proper counsel the patients, plan for trabeculectomy with a mitomycin C in right eye and conservative treatment in left eye because IPO will maintain. So this is a live surgical video. So this is a live surgical video. The following preventive measures taken. The first, we use the peribulbar anesthesia, just 1 ml, and no bulbar massage. AC maintained throughout the procedure because in case of macular split, there is a more chances of wipeout for this reason. And I'm using the pre-placed scleral sutures. And the releasable sutures, that is controversial, some surgeons prefer, some surgeons don't prefer. So the post-op day 1, there is a diffuse oil from blade, visual acuity 4/60 as seen before, and the GAT was on 8 mm of HG, and the post-op day 7, the diffuse oil from blade, visual acuity 6/60 and the GAT 10 mm of HG. So this is my work that was published in Indian Journal of Ophthalmology 2022, the prospective evaluation of the wipeout after glaucoma filtration surgeries in eye with split fixation. So conclusion, wipeout is a rare phenomenon after surgery in advanced glaucoma. So my take-home message, the surgery should not be withheld due to the risk of wipeout when target intraocular pressure cannot be maintained medically with an advanced stage of glaucoma. Thank you.
Thank you so much, Doctor, for summing up the challenges. May I request our discussant, Dr. Moitri ma'am, to...
Thank you very much. Both presented the extreme situations of the secondary glaucoma. So coming to your case first, pseudoexfoliation glaucoma is quite common nowadays because of this. You know the reasons, because of this ultraviolet rays and urban areas are more affected. Only thing is that pseudoexfoliation glaucoma, there is a high chances of the zonular dehiscence. So you always be very careful, and these are refractory glaucomas. So always we should do the trabeculectomy along with some kind of antifibrotic MMC or 5-fluorouracil, whatever we are comfortable with, because these are refractory glaucomas. So these two things, if you combined it with a cataract surgery, I think the better it will be if it is a quite advanced stage. Do the trabeculectomy first and let that thing get the modulation done, and then other side you do the cataract surgery. That works better. And otherwise follow them up. For the pseudoexfoliation, people might not be getting glaucoma also, but the follow-up will be very close follow-up.
Yes.
That's in one way. And for your pigmentary glaucoma, and some of the situations you'll be getting only pigment dispersion syndrome, where the glaucoma will not be there. But once it starts, the patient starts getting the high IOP, they develop the glaucoma, and the rate of progress is quite fast. So they also need very close follow-up. And coming to your macular wipeout, the most important thing you have mentioned it here, that you should not delay the surgery, and wipeout phenomenon is not that common. But one thing you should give the message that for the wipeout phenomenon, IOP fluctuation actually makes the difference. If there is a high IOP fluctuation, if you are not reducing the preoperative IOP that way good, then the wipeout phenomenon is common. And post-operative also, if you are using this, releasable suture, so whenever taking the releasable suture out, if the IOP drops off from very high to very low, these are the situations that's very difficult for the optic nerve to withstand. That has to be kept in mind. Nilo, you would like to add?
So to add to that, I have seen in my dislocation of the bag with IOL after 20 years of cataract surgery and pseudoexfoliation. So that is a possibility also. It is not that cataract surgery once done, everything is fine. So they are to be constantly followed up as long as possible. Thank you very much.
Yes. So where pseudoexfoliation is concerned, we have to take care of that part, zonular weakness. And one interesting fact about this pigment dispersion syndrome is, with age, the glaucoma improves. So there are some cases where we get some amount of pigmentation at the angle, glaucomatous this changes, but IOP is normal. That comes in the DD of normal tension glaucoma. But you all, in such cases, if we have doubt, we should always take the history of past treatment, etc., and look for pigments in the angle at least.
For Tanya. Thank you so much, sir. Now, as a keynote address, we are very fortunate to have Dr. J.S. Bhalla with us today. He will be speaking on role of ocular perfusion pressure in glaucoma. He's an alumnus of Maulana Azad Medical College, New Delhi, and he's presently the Secretary of DOS, Member of Scientific Committee IOS, Chairman Scientific Committee Delhi Chapter, and he has been awarded nationally and internationally. He has the Best Paper Award for OptaQuest 2017-2018, Best Paper Award and A.C. Agarwal Trophy by DOS in 2018. He's the Chief Editor of DOS Times on editorial board of IJO and Delhi Ophthalmological Journal, and he's the reviewer of Asia Pacific Journal of Ophthalmology. Free paper awards, thesis and videos as AIOC, delivered keynote lectures and conducted instruction course at annual AIOC. A warm welcome to you, sir.
Thank you at the outset. I'm grateful to Dr. Sudipta and OSWB for giving this opportunity. I'm just going to touch briefly on the role of ocular perfusion pressure in glaucoma. As we all know, glaucoma is a progressive optic neuropathy of unknown origin, and traditionally the diagnosis and treatment has been directed towards the control of intraocular pressure, which is the single most modifiable risk factor. But various trials have shown that glaucoma progression occurs despite IOP reduction. These are ocular hypertensive treatment study, EMGT, CNTGS, advanced glaucoma intervention study, and collaborative CIGTS. So glaucoma is a complex disease that cannot be controlled only by intraocular pressure reducing therapies in all the patients. So it represents a spectrum where mechanical damage caused damage at high intraocular pressure and vascular damage caused damage at low intraocular pressure. And 60 to 80% of the glaucoma patients have vascular insufficiencies, which cause decrease in the intraocular pressure. Lagrange, way back in 1922, was right in pointing that glaucomatous eye is a sick eye in a sick body. So we all know that vascular theory was given by von Giger way back in 1858. So what are the other risk factors besides intraocular pressure? These can be non-vascular and vascular. In the vascular, we have the vascular disorders like diabetes, systemic hypertension, migraine, disc hemorrhage, systemic hypertension, and low ocular perfusion pressure. Why aging reduces ocular blood flow? Because the choroidal thickness decreases from 200 to 90 microns. 47% of glaucoma patients have hypertension and 30% have diabetes, which causes decrease in ocular blood flow. Also in migraine, there is reduced ocular blood flow. So in glaucoma patients, it has been found that decreased blood flow occurs not only in the optic nerve, but also in the retina, choroid, retrobulbar vessels, brain, and peripheral vascular system. So primary insult happens at the optic nerve head, and secondary insults happen if the ocular perfusion pressure falls below the lower limit of autoregulation. So there is not only decreased ocular perfusion pressure, there is also autonomic dysregulation, and this dysregulation causes there is no adjustment of ocular perfusion pressure when the blood pressure falls or the intraocular pressure rises. So these are the various factors besides raised intraocular pressure, and of these, one of the important factors is also reduced ocular perfusion pressure and OPP fluctuation. And this was sixth consensus publication in the World Glaucoma Association, which found that low ocular perfusion pressure has been identified as an independent risk factor for the glaucoma progression. But do we have adequate evidence to justify routine assessment of ocular perfusion pressure in all our glaucoma patients? But recent population-based studies have found that low OPP is not only a risk factor for development, but also for progression of glaucoma when you reach the target intraocular pressure. And what is ocular perfusion pressure? I'll just simplify. Systolic ocular perfusion pressure is systolic BP minus IOP, and diastolic BP minus IOP is the diastolic perfusion pressure. And it has been found that low diastolic perfusion pressure less than 50 millimeter mercury was associated with high OAG prevalence in various epidemiological studies. And 5 major epidemiological studies have provided data on the relationship between ocular perfusion pressure and glaucoma. And these are Baltimore Eye Survey, Egna Newmark Study, Pro-October, Los Angeles Latino Eye Study, and Barbados Eye Study, which found that the decreased ocular perfusion pressure was associated with higher glaucoma risk from 2-fold to 6-folds. And these are the other studies: EMGT, Los Angeles Latino Eye Study, Thessaloniki Study, Blue Mountain Eye Study, all found that there is a correlation. And what are the various hypotheses? One is that subjects treated for systemic hypertension, they may lead to nocturnal hypotension. And second hypothesis is antihypertensive treatment disrupts the vessel's natural ability to auto-regulate at any given ocular perfusion pressure. So Wienrep said that the diastolic BP compared to systolic BP has a greater effect than systolic BP, and Greenfield actually quantified this correlation between the perfusion pressure and glaucoma. And so what we find is that in glaucoma patients, OPP is lowest around 7 AM. Why? Because the BP is lowest at this time and the intraocular pressure is highest. So the difference becomes, leads to lower ocular perfusion pressure. Yes, now various mechanisms are there to measure the ocular blood flow. These are the various modalities. But by these color Doppler, it has been found that there is low peak systolic velocity and end diastolic velocity, not only in ophthalmic artery, but also in central retinal artery and short posterior ciliary artery. And the current imaging modalities involve the use of OCT angiogram, where they have found that the microvascular network in the optic nerve head is quite less compared to the normal discs. So what are the facts favoring the measurement of ocular perfusion pressure in glaucoma? We find that normotensive glaucoma patients have associated occurrence of asymptomatic MI. Then NTG also have, just 30 seconds more, ma'am. So NTG patients have increased variability of nighttime BP measurements, and there is documented role of OPP in progression of glaucoma in epidemiological studies. And there is nail fold capillary abnormalities in POAG has been found in normotensive glaucoma patient associated with cardiovascular disease. Low glomerular filtration rate and cerebral vascular deficits have been found on MRI in normotensive glaucoma patients. So what are the patient subgroups in which we should routinely assess ocular perfusion pressure? Normotensive glaucoma, eyes with disc hemorrhage, patients with progression at low IOP, patients having nocturnal hypotension or on multiple antihypotensive drugs. So while the relationship between the blood flow and glaucoma is well established, the nature of that relationship is still not very clear. And we still don't know which factor of these perfusion pressure, whether IOP alone, BP alone, or combination is more important. So circumstantial evidence of vascular involvement in glaucoma has been bolstered by experimental evidence. Vascular theory has not muscled out other theories, but time has come to take OPP seriously. So time has come to think beyond IOP. Concept of glaucoma is shifting now from a disease of single pressure to a disease of multiple pressure. So the convincing relationship of OPP as a risk factor is just like a high-hanging fruit. It is there, but beyond the reach of our present-day evaluation capabilities. And the ultimate beneficiaries of work in this area will not be researchers, but our poor glaucoma patients. Thank you, everyone, for your kind and patient hearing.
Thank you so much, sir, for such an extensive discussion. Now, may I request our discussant, Dr. Tutul Chakraborty, if she wants to add on something with her valuable opinion.
Thank you, Shohini. Thank you, Sudipta and Tulika. Nothing to really add because he covered everything, Dr. Vallabh. Just to the gist that low diastolic pressure and high intraocular pressure that causes low ocular perfusion pressure, and less than 30 millimeter of ocular perfusion pressure increases the 6-fold risk of primary open angle glaucoma, and other 56 millimeter of mercury that could save the patient, because improves the ocular perfusion pressure. Regarding treatment, that is some patients, the nocturnal BP falls. For them, already you have mentioned, for them rather not to use beta blocker at night, beta blocker orally and beta blocker topically. Second, perhaps, we should be cautious that those who are having systemic hypertension, don't treat them over enthusiastically, because that can damage the, because perfusion pressure will be low and glaucomatous loss will be more in that case. And one additional point, that is ocular perfusion pressure improves, especially the diastolic one, if we add dorzolamide timolol fixed combination and latanoprost 0.005%, that improves the ocular perfusion pressure. Thank you.
Thank you so much, ma'am. Now, may I request our chairperson, Dr. Parag Mukherjee, sir, if he has to say something.
Nothing much to say, but at the end of this session, my take-home message is, as you know, glaucoma to be a disease of optic neuropathy. Here, after the session, I realized that vasculopathy and optic neuropathy both work hand in hand.
What is the role of endothelium in this? Is it also involved in this glaucomatous disease?
So that is one theory. But why does it occur and why we have association of migraine with normotensive glaucoma? They found that there is a secretion of endothelin, which is a vasoconstrictor and which causes decrease in the ocular perfusion pressure because of vasoconstriction. So there is a role of endothelial pathology is also there. And coming to Dr. Tutul, I think she very nicely said, whenever we have this comorbidity of hypertension in our glaucoma patients, we should discuss with the physician and cardiologist that instead of giving beta blocker, it is better to give calcium channel blockers, number one. And number two, don't give it right at the sleeping time. It should be slightly shifted much before in the evening time. That is one part, and definitely amongst the anti-glaucoma drugs, class of drugs which increase the ocular perfusion pressure is carbonic anhydrase inhibitors, dorzolamide, brinzolamide, And the other important drugs are ROCK inhibitors, which also cause increase in the ocular perfusion pressure. So these group of drugs, they are really helpful wherever you find that the target intraocular pressure has been achieved, but the patient is still progressing, or the patient also have coexisting hypertension and is on multiple antihypertensive drug. It is better to add these subgroup of drugs rather than other alpha agonist and other group of drugs, beta blockers.
Dr. Bolasa, I have a question, a burning question actually. So should we be measuring ocular perfusion pressure in all our glaucoma patients?
I think that's a very good question, ma'am. It is an important factor, but right now it is not possible to measure in all the patients. It should be measured in all subgroup of glaucoma patients where you have disc hemorrhage, patients of normotensive glaucoma, patients who, in spite of achieving target intraocular pressure, continues to progress, patients who are on beta blocker antihypertensive drugs, which causes nocturnal hypotension, and patients who are on multiple antihypertensive drugs. These are the subgroup of patients where you should measure ocular perfusion pressure. And like we have done a study also by measuring the ocular perfusion pressure in central retinal artery, short posterior ciliary artery, and ophthalmic artery by color Doppler imaging. But right now we have OCT angiography, which can easily document without undertaking those difficult investigative modalities.
Thank you so much, sir, for that exhaustive talk in such a short time.
Although I don't have a slide, I also just want to appeal from your platform. I need support of all of you, esteemed members, for my candidature for the post of Member Scientific Committee at IOS. Thank you, everyone.
I have a question for Tanya. Where is Tanya? Where is Tanya? Yeah. Tanya, your patient is myopic? I mean, the pigmentary glaucoma. So any extra, I mean, how much myopic the patient? Yeah. Do you have any reverse pupillary block in that patient, and do you think that CRPI is any role of before surgery?
Because this is a case of advanced glaucoma, so for this reason.
Both of you, can you, instead of whispering, talk in the mic? Mic is there in hand.
Yeah, he has a great role because before surgery, because it's a reverse pupillary block. It's a very rare phenomenon. Yeah. And three things you didn't mention, that is triad of the transillumination and Zenpea line, right? So Krukenberg spindle, Zenpea line, and transillumination defect. It's a three, diagnostic thing for the PDS. Thank you.
Very well mentioned, Tutul Chakraborty ma'am. And with that, we come to the end of this session. And thank you, speakers, panelists, and chairpersons for this. Now we hand over request. We have the session for handing over retina session. Before that, we would call upon Dr. Parag Mukherjee sir. Please come over and hand over memento to Dr. Suchitra Majumdar ma'am. Memento to Suchitra Majumdar ma'am. ऐसे देखो, ऐसे ही तो सामने है. Ma'am, please come over. Can we have a round of applause, please? Please stay back. Shohini, you are the moderator. And Dr. Suchitra Majumdar ma'am, please hand over the memento to Dr. Parag Mukherjee sir. All of you, please stay over for one more, please. Thank you. And now I request Dr. Amarnath Dey sir. So please come over to hand over memento to our speakers, Dr. Dr. Tanya, Dr. Tanya Roy Bhadro and Dr. Shobhoshachi Patnaik, who walk together. Please come. No. Both of them have in their own names. Please come over. They walk together, so they'll have the memento one by one. Dr. Shutapa Roy and Dr. Alokesh Ganguly. Dr. Harshul Tak and Dr. Nazneen Azam. Harshul, I think can come and stand for a photograph. Yes, please, sir. Dr. Harshul, you have to come and stand next to Nazneen while she takes a memento at least. Yeah, okay, you can go and sit. Come and sit. Okay. Dr. Nazneen. Dr. Nazneen Nazam. Nazneen kothay? No, not that. Oh, hers is missing. Oh my God. Take it. Harshul is, the memento is given out, yes. Our Secretary, Dr. Debashish, thank you, sir. Dr. Debashish Dash to hand over memento to the panelists. Dr. Nilay Mujumdar, sir. Dr. Nilay Mujumdar, Dr. Moitri Dash. Dr. Moitri Dash. This, okay. Chala, okay. It's all in the house. Okay. And Dr. Tulika Ghoshal. Dr. Tulika Ghoshal, ma'am. চা খেতে গেছে আচ্ছা ঠিক আচ্ছা হ্যাঁ টুটুলি ডক্টর টুটুল চক্রবর্তী কাম সরি ডক্টর টুটুল চক্রবর্তী প্লিজ কাম ওভার and last but not the least Dr. Shubhashish Nag sir, my mentor in OSWB. I hope I have not missed anybody. If I have, please point me out, and please all of you come over for a group photo. The chairpersons, the speaker, the panelists, please come over. Yes.
Our main today's host. See, we are walking hand in hand, but I see so many of our national guests who have come from all over. So let them walk hand in hand. At least they are walking, but let them walk hand in hand, come over here and just tell each of them that I am the candidate for this post. So let's see them. Let them hand, that's my request.
Sir, just before the photograph, Dr. Srini missed it in the...
Yeah, no one can miss Srini. He's the most prominent person. Literally.
I am Dr. Kasturi Bhattacharjee. I am from Sri Shankardev Netral Guwahati and also a life member of Ophthalmological Society of West Bengal. I request for all your blessings, love, support as I am contesting for the post of member ARC East Zone. Please do help me, please support me.
Each one of you have got 1 minute.
Srini, just take a memento first from sir.
Okay.
Can we have a round of applause for Srini? Srini was there in LDP with me, so was Piyush and Dr. Sabasati Patnaik.
He is the joint organizing secretary there, and I request all of you to go after Kochi, you register immediately for Kolkata, where I am the organizing secretary.
As I said, I'm Srini Adaklon. I'm the chairman of the scientific committee of Kerala Society of Ophthalmic Surgeons, and I'm standing for the post of member ARC South. Just 1 minute, like in our school days, there was a chapter which says Bengal and Kerala are just the same. It's just the language is different. At that time, we used to have communists ruling both states. Now only Kerala has. And my father was here till 70s. and he used to play, I mean, he was an engineer and he used to play in the second, third division football. And any chance he gets to speak Bengali, he loves it. And he's really happy that I'm here. And thanks a lot for this opportunity.
I will also just add one thing. My dad also studied in Narendrapur, and I'm also married to Bengali, and my Pishi all are here in Salt Lake. So Kolkata is always a second home to me. And every year when we were young, my dad used to bring us to Narendrapur. We used to go and see what they used to do. It's something so blissful. And he just left us during the COVID time. I'm really missing him now.
Yes, Piyush. Piyush has come all the way from Pune.
Thank you, Sudipta. Very good afternoon. My name is Piyush Bansal. I am a solo private practitioner in Pune. I practice vitreoretinal surgery after training from LV Prasad Eye Institute in Hyderabad. My young steps are I'm secretary in Pune Ophthalmological Society and past member scientific of the Maharashtra Ophthalmological Society. And I don't have any Bengali associations. Like maybe I'll find nice Bengali to say. No,
Nice Bengali wife.
But it's always lovely to be here. Thank you, Sudipta, for the kind invitation.
Yes, we are there for you. Why no one from you? We are all here for you.
We met at the AIOS LDP.
LDP. We were in the same batch of LDP.
I am humbly contesting for member scientific committee of the AIOS, and I would request and for your support. Thank you.
I am Dr. BNR Subudhi from Odisha. I think most of the people know me, and I know all of you here. I am the really, what do you say, for the revival of IJOC. We have worked a lot. Ratish is here. Devashish must be knowing, telling us. So I am contesting for the post of editor proceedings, All India Ophthalm Society elections 2023. And from the core of my heart, I request all of you, because Odisha is not far from you, and always I am associated with the West Bengal Ophthalm Society. Request all of you to again vote me and give an opportunity to represent IJOC in AIOS. Thank you very much.
Hi, good afternoon once again to everyone, and thank you so much for giving this, this extra opportunity to us. I'm Somshila Murthy, and I'm currently one of the members from the scientific committee, just like Dr. Bala. And I'm recontesting for the same post. So there are 3 of us who are contesting for member scientific committee, but as you know, there are 7 posts for that. So Piyush, he's such a nice guy, so definitely, and he's very capable. And Dr. Bala and I have worked closely together. I think our best connection with Bengal is having worked with Dr. Partha Biswas, who I'm pretty sure he's a typical Bengali, I'm sure, but he's been an amazing person. And if this is what Bengal is about, I think that we'll be so happy and delighted that AIOS meeting is coming back to West Bengal. It should have been there last year or the year before that, but it didn't happen, so it's going to happen now. So let's hope that we are at the helm when that's happening, and we'll work closely with you when that's happening for the scientific program. We all just are behind science. We want science to represent, we want science to be there in AIOC, in all the meetings, and nothing else. So that's a common agenda all the time. And if you've seen I know there are a lot of complaints for the previous meetings, but if you've noticed any changes, it's because of the free hand that Dr. Biswas gives us. And our only agenda has been to push science. And so I'm from a very academic background, from LVP, and that's the only thing. There's no politics, it's only science for us. So please support us. Thank you very much.
Bala sir.
Yeah. Good morning, everyone. I'm Dr. Jatinder Singh Bhalla from Delhi. I'm Secretary of Delhi Ophthalmological Society, and I'm really very sincerely grateful for being given this opportunity to talk in front of all of you. Like Dr. Somshila said, we have worked closely together and under the captaincy of Dr. Partha Biswas, who has been an amazing leader. And what I want to say is that I represent a small hospital in Delhi. It's a government hospital. And with our efforts, we have been, although it was a very small hospital, but we have worked hard to bring it within the first ranking in DNB courses all over the country, where it was no rank at all. And similarly, working for DOS, what I have been able to do as library officer was we launched various apps which were very user friendly, so that any article from any journal could be given to any member within 24 hours. And we launched some apps also where you're just sitting on your smartphone, you just click on the article and you can download all those articles. So at the end, I'll say that we just represent science, no politics. And what I believe is science is an organized knowledge, and scientific committee is an organized wisdom. So I just pray to all of you to let me contribute my knowledge to wisdom of all of you. Thank you, everyone.
Well, I think that brings us an end. And
One
as you have
memento.
seen, OSWB and Bengal, we are really, that way we are large-hearted. We really welcome you with our heart, and we hope that each of you get the full support of not only Bengal, but the whole of India. And we want you to work for science, for AIOS, and bring up our societies. In West Bengal, in OSWB, we don't do politics whenever the elections are over. Yes, for the elections, we do politics. So I hope you will reciprocate the same for us whenever our members go to your place. Thank you.
Just thank you so much. And just continuing with the scientific sessions, Dr. Tulika Ghoshal, please take your memento from Dr. Shubhashish Nag sir, glaucoma session. And somebody who was behind the screen and is putting us on time is Dr. Priyam Biswas, always saying 1 minute left, 1 minute left. She has to do it once more for another session, but I want, our memento is there, of course. So this she really does. And let me tell you, she is hurt. She is having her injured leg. And even after that, she's constantly after, and she's hyper excited to join this session. Thank you, Priyam. What would I do without Tulika Di and Priyam? Please, sir, do not go. A beautiful moderator of glaucoma session, Dr. Shohini Ghosh. Please hand over the memento to her. Thank you so much, all of you. And with that, we come to the end of this glaucoma session and the photo session. I hand over to Dr. Siddhartha Ghosh to carry on with the retina session, please.
Thank you, Sudipta. Welcome you all to this retina and UVA session now. Let me welcome our chairpersons for this session, Dr. KP Ghosh sir and Dr. Mohammad Yasin sir. I think both of you are there. Dr. Yasin sir, yeah, okay. And let me also welcome our panelists, Dr. Devashish Das, Dr. Rupak Kanti Biswas, I think he has left for some urgent work, and Dr. Aniruddha Maiti, Dr. Tripti Kauntia. Would you please come over in the front table so that it becomes easy? Okay. May I also welcome Dr. Vivek Datta, Vivek Da. Please come as a panelist. Your expert opinions will matter. Please come. And let us start the program now. And I welcome the speakers. The first set of speakers would be Dr. Sneha Jain and Dr. Somen Mondal. Could you please come over the dais? And because we are already running short of time, I suppose. So let us start the talks first. Dr. Sneha Jain is a prolific surgeon with Indian Railways and GD Diabetes Hospital, and she will have the first talk. And the topic is a second chance to survive secondary rescue IOLs, you know. And the second speaker will be Dr. Somen Mondal, who is a prolific surgeon, but we all know his passion for photography. We have all enjoyed, and we'll also see it later in the next session. Well, for any cataract surgeon, it's really a nightmare not to, and it's very depressing not to be able to put implant an IOL after a good cataract surgery. But we can have heard, because Now we have the secondary IOLs to our rescue, and let us hear it from the expert speakers now. Over to Dr. Sneha Jain.
Okay. So I'm sure no one in this room likes to keep their patients aphakic. So be it a case of a severely subluxated, dislocated IOL or lens, or a surgical aphakia. And when there is no possible way to place the IOL in or over the bag, secondary IOLs come to the rescue. A very good afternoon to all. I'm Dr. Sneha Jain, presenting a second chance to survive secondary rescue IOLs. Now we have multiple options like the conventional AC IOL, the now popular retropupillary iris claw lenses, and the scleral fixated IOLs, provided the iris tissue is not damaged. But what if the iris tissue integrity is compromised? Here comes the hero of my talk today, the scleral fixated IOL. There are multiple techniques to do the SFIL, both sutured as well as sutureless, with multiple variations, but the basic principle remains the same, that is to place the lens in the sulcus and the haptic to be fixed exactly 180 degrees apart, centered on the cornea. So today I'll be sharing a few techniques that I have done so far. Started my SFIL journey with the sutured IOLs, 4 points fixation technique using polypropylene sutures, where the sutures were used to thread the eyelet of the rigid single piece SFIL and suspend the IOL in the sulcus. But it was very time taking, and it involved a lot of tying of so many knots. So then moved on and tried the intrascleral fixation of the haptics of 3-piece lens into the Gables tunnels, which are basically partial thickness scleral pockets made 180 degree apart, 2 millimeters from the limbus, starting a little away from the site of exteriorization of the haptics and running almost parallel to the limbus, tapering as it ends. A 3 to 4 millimeter tunnel is sufficient. The right side always pointing away from the surgeon and the left side one towards the surgeon. Now to exteriorize the haptics, initially use this technique with foldable 3-piece lens, where all the manipulations of the docking were done inside the eye. Now, taking out the first leading haptic was fairly fine, but then getting the second haptic docked and out of the eye was a challenge in itself. So I shifted to the X-net, where all the docking and manipulations were done outside the eye. So after doing a good vitrectomy, the scleral corneal tunnel was open, and a 26 gauge is pierced 2 millimeters from the limbus behind the iris, guided out of the tunnel carefully so that to avoid iris tissue or corneal tissue incarceration. And now the haptics are docked into it. With one smooth movement, the haptic is exteriorized. Now the same is repeated on the other side, and with very gentle handling of the trailing haptic to bring it out, while the assistant holds the leading haptic. Now once both the haptics are exteriorized, they are fed into the scleral pockets using the microforceps, and the centration is adjusted. A few things that I would like to highlight, which I started using recently, is this trocar as an AC maintainer, which is inserted in a valvular fashion 0.5 millimeters from the limbus. Also, I used to face the problem of localizing the scleral pockets. So for this, mark it with a blunt cannula, which is stained with a tissue marking pen, or simply, as in this case, what I've used is basic trypan blue dye, which is injected into the tunnel. So also to decrease the dependency on my assistant, started using these 240 bands as a stopper for the leading haptic, and it's slided over the 26 gauge needle onto the haptic as it exits the eye. Lastly, I want to end by saying that's not enough only to manage the IOL situation, but if necessary, to also perform a pupilloplasty or an iridodialysis repair to truly give the eye a second chance for good vision. Thank you.
Wonderful videos that were really not from a young consultant, but a masterly consultant who has done wonderful work. Thank you so much. We'll come to the discussion a little later after Dr. Somen Mondal gives his presentation. And Dr. Somen Mondal is a prolific surgeon again from Disha Eye Hospitals. He's a great consultant, but a great photographer. Let's see a look at his presentation.
A very good afternoon. So as Sneha has already shown, that on-table rescue procedures have evolved. Now she had demonstrated so well regarding the SFIOL. I would like to discuss a little about the retrofixated iris claw lenses. They are basically, it has a shorter learning curve, and the suture related complications are much less. It doesn't interfere with the angle structures, and it does not affect mydriasis. So this is what a retrofixated IOL would look like, and this is the way it is held in the anterior chamber while it's been enclaved. So I will straight away go to my second presentation in want of time, second video. If we have time, we can go for the first one again. So this is a case where there has been a posterior dislocation of the cataractus lens. So I make a tunnel, an SICS tunnel, and there you can see that the lens is dislocated posteriorly. So I'm converting one of my ports to a larger one, a 20G1, so I can enter my fragmatome, and phaco-fragmentation has been done. I'm completing with the phaco-fragmentation. Now I have just made a tunnel at the 9 o'clock and 3 o'clock position. I'm ensuring that there's no vitreous in the anterior chamber. It becomes very difficult. If there's vitreous, I enter, I open my SICS wound. This is the IOL. Now we have to make sure that the haptics open and close properly just before inserting, so that the enclavation is done properly. And now this is how we are inserting the lens. Then the lens is kept into position. The 3 o'clock and 9 o'clock position of the haptics are ensured. You catch hold of the
So there's 1 minute
retrofixated
more.
lens, and now the left-hand haptic is inserted. We have a Sensky hook. You just tap and it enclaves. Change your hand, have it now. We are inserting from the right-hand side. Again, the Sensky is inserted, a tap, and it is done. Nice round pupil at the end of it. We can have further discussions on the procedure later on. So usually SFIL is technically a little more challenging, but retrofixated IOLs, the learning curve, as I said, is much less. It has a lower rate of complication, and it might be preferable, especially for the anterior segment surgeons, as a rescue procedure in a primary setting. Thank you.
Thank you, Dr. Showman. Wonderful teaching video, wonderful. Let us come for the discussions, and I'll first invite Dr. Vivek. Vivek, your inputs on these kind of techniques.
Thank you. Sneha's presentation was wonderful. You know, I often found it so difficult to negotiate the haptic into that needle. So, but you have brought out a new dimension to the whole thing, and wonderful video, and your presentation was also excellent. So one thing I just worry, I mean, how do we ensure that it has properly got, the iris tissue has got embedded there?
Yeah, it's very easy to see. You'll see that there's a small crinkle where it has enclaved. If that crinkle is not there, it has not enclaved properly. So you'll just see that pinch. And what I wanted to mention in my presentation was, make sure that the pinch that is happening is more towards the periphery than towards the pupil. If it's more near the pupil, you will end up with a cat's eye. So it has to be somewhere in the middle, from the limbus and the pupil. Somewhere in the middle, a little more towards the limbus.
Just I want to share one experience. I've seen a patient who had a Daljit Singh's IOL implanted, similar type, in front of the iris.
Yeah.
Yeah.
Now,
and that lens, what happened? He came to me with a history of some injury, poking finger injury in the eye, and one haptic got dislocated from the lens. Whole lens got dislocated. With one haptic got free from that iris tissue.
Yes, yes.
So I think this is very important. Even if it is posterior to the iris, that trauma-induced dislocation risk is very high. So we have to caution the patient. Even later on, they can have some problems.
Yes, yes. Actually, Daljit Singh's IOL was it was not a retrofixated. It was an AC iris claw. What we are doing now is a PC iris, retrofixated iris claw, which is down below, not in the AC.
Right. Thank you. After a comment from Dr. Piyush, we'll take comments from Dr. Aniruddha.
absolutely gorgeous videos, Sominda. Just one point I wanted to add, how I do things slightly differently for the iris claw lenses. I would pretty much do it the exact same way that you showed the video, except that now instead of holding it via the iris claw holding forceps through the main wound, I make two diametrically opposite micro incisions on the limbus, and then I use a forceps, could be a serrated forceps, could be a end grasping forceps, and hold the haptic of the opposite side, then taken your instrument from the second instrument, which could be a dialer, could be any such instrument, from the Sinsky, and then going from the opposite side, and then just stuck some part of the iris in the haptic cleavage, and then repeat the same thing on the other side. So I just find it technically to doing it, it's a small modification, but it reduces the pressure on the globe. That's what I have felt.
Number two, one interesting part in your technique is that you don't need that special iris claw forceps. You can use any forceps for that. Right.
Exactly.
Good.
Shominda,
yes,
I think the way we can understand that it is properly enclaved, there's another method. Sometimes we don't see the dimple. If we see the dimple, it's
if it's a thicker iris,
sometimes we actually what do we enclave it and pull the lens and see whether the iris is coming along it. I think that's a practical tip, and I've
Definitely.
been doing this procedure for the last 10 years and I'm pretty much happy. Most of the cases we can do unless and until the iris tissue is grossly injured. And other two procedures I think we have missed in the presentation, but that they're pretty useful with this Yamani's technique. And there is a new lens from Appa, which is also pretty, it's a CMT flex. And that's pretty useful, like a foldable lens at a T-junction, you just take it out and it's a pretty much centered and easily done procedure.
That was great, and thank you. I think that is a very important point made. What are the contraindications of, retrofixation of IOLs? Yeah, Dr. Devas.
Just wanted to know from Showman, what are the chances of any complications, like it is slipping the iris?
It does happen, yes. Sometimes it does happen. When on table, I have faced this problem, and later on also. On table, initially, when that dimple was not there, I was not very sure whether it is dimpled or not. I actually used to tap a little. And the moment, once it so happened that I tapped and it just went down. So one haptic was enclaved, the other was not. So it was dangling like a pendulum. It's very easy to manage that. You just enter with a light pipe, lift it up, because I have 3 ports, right? So you lift the lens up with your light pipe, hold it with your enclavation forceps, take it up in the AC, and then you repeat the procedure.
And does the iris atrophy over the
till there would be, theoretically, there would be a little bit of iris atrophy, but again, the amount of iris that we are enclaving, that is very less. So I have been doing it for the last 5 years. I have to see, say, 15 years down the line, whether how they are doing.
Is there any late slippage of the IOL? Not on the table, later, down the line.
I had 2 or 3 patients who had been referred from outside where there had been slippage of the IOL and it had been salvaged the same way.
Correct.
I think it's better to avoid the atrophic area, and it's pretty easy. You have to be 180 degree apart. So you just avoid that atrophic area, and you can put it, instead of 3 and 9, you can put it in the other way.
It doesn't, absolutely, it's not necessary that you have to put it in 3 and 9. You can just... It's 180 degree, that is important.
And another thing, like the flipping of the IOL, sometimes the anterior segment surgeons put an AC maintainer. So that is a condition, it is very difficult to put the lens in position. So it's always better to have an infusion port and do the iris. The system is more stable.
And another important thing is you have to be 100% sure that there's absolutely no vitreous in the plane of the iris. If there's a little amount of vitreous, that will meddle with your enclavation.
Thank you, Showman. I think we'll move on to the next topic. And may I invite Dr. Piyush Bansal and Dr. Sangeeta Roy for the next topic. And the topic is dealing with the retinal IOFBs. And as we all know that the commonest location of IOFBs are, the retina and the choroid. So this will be interesting because we are going to see the very important points of dealing, how to diagnose and deal these patients with IOFBs. And Dr. Piyush Bansal needs no introduction. He has just introduced himself. We all know that he is a very dynamic, courageous surgeon from VR surgeon from Pune. He is a solo practitioner, and Dr. Sangeeta Rai is a consultant VR surgeon, and she also has a passion for teaching. Right. So over to Dr. Piyush. We'll wait for his presentation now.
Thank you so much, sir, for the kind introduction, and thank you for this warm invitation as well. It's always a pleasure to come to Kolkata and to West Bengal. During the daytime, it's a lot of scientific feasts, and then it's the street food that really drags you in the evening. So what we'll be talking about is, like sir said, intraocular foreign bodies and some various techniques or scenarios that one can use. I like to call this the irony of iron intraocular foreign bodies. Now, the first case that would be coming up over here would be of a foreign body that is stuck in the pars plana. You can localize it in the imaging. You can examine it and then mark it like you can see over here. Then what is important is we are not going to enter the vitreous cavity at all. You, after dissecting out the conjunctiva, one can make partial thickness scleral flaps, or one can also go ahead and do a complete thickness scleral flap. I prefer doing partial thickness, as you can see over here. And after that is achieved, you're going to expose the choroid. This is obviously after you've localized the foreign body and marked it. And after that is done, when the choroid is exposed, you can cauterize it a bit because you're going to make an opening in the choroid. And as you can see over here, after the opening is done, you might have a little bit of vitreous prolapsing, but you take your magnet in that time, and that is when you tease the foreign body out. Sometimes it comes in with much more ease. Obviously, clearing out the vitreous is important. This external method would be preferable when you don't have any other breaks, any ricochets, and there's no need for you to actually enter the vitreous cavity in such situations. In those situations, it's a comparatively good way to give a good prognosis. Another scenario where you have a traumatic cataract, so after clearing it out and you already have a posterior capsular rent, so in such a situation, you're going to have to leave the patient aphakic anyways. So you can, after removing the foreign body, as you can see over here, use a PVD and clear out all the vitreous. If there's any encapsulation, you get rid of all the encapsulation around the foreign body. Pick it up, you can use a magnet, or you can use, as you can see, with the one hand, the magnet was used, the foreign body was brought up, held with a forceps in the other hand, and then you're using a wire vectis. The reason I used a wire vectis was I didn't have another intraocular foreign body holding forceps that time. And then you can laser off whatever remains. Another similar situation where you have a phakic patient, and this time you can't bring it out through the limbal route, so you're going to have to get it out through the scleral route. So after doing all the necessary PVD inductions, etc., you bring the foreign body up using a magnet. Now in this particular case, as you can see, the size of the foreign body seem to be larger than the scleral incision. One can also put in PFCL so that it kind of gives you a kind of a cushion if the foreign body falls in. And you can use a handshake technique. You will bring up the foreign body with one forceps, use the other forceps.
So we have a minute to go.
Thank you. So, and get it out. Another similar situation where now this is a comparatively larger foreign body as compared to the previous one. Again, can't bring it out through the limbal route. So extending, getting an idea, gauging the size of the foreign body earlier itself, and then extending your scleral incision, holding it with your forceps or your magnet and getting it up. And then using some amount of pressure on the posterior lip and getting the foreign body out. No minimal disturbance to the anterior segment. Another situation where it's not going to be possible to get it out through the limbal route or through the external route. So extending your scleral incision, and as you can see over here, sometimes while getting the foreign body out, it might also get stuck in the ciliary body. You just have to maneuver it a little bit, and you can use another instrument to just gradually kind of tease it out. Thank you very much.
Thank you, Dr. Piyush. Wonderful as usual. And we will take the questions a little later after Dr. Sangeeta has her presentation done. Over to Dr. Sangeeta.
So I'll be showing three scenarios. So this is the first case where it was a vegetative foreign body, the patient was referred to me by another retina surgeon who couldn't take out the foreign body on table. So this is the foreign body. I removed the oil and the foreign body was stuck around at the pars plana. So I nudged the foreign body a little bit with my cutter and the illumination pipe, and the foreign body was released. So yeah, so there's a small chip of wood that is coming out. I held it with a forceps and taken it out. The rest of the foreign body was quite big. It would have been difficult for me to hold the whole thing. And it came out smoothly. The patient was left, so I put the lens so that there is no more complications with aphakia. This is a second case. Again, the patient was referred to me because the surgeon couldn't find the foreign body on table. When I saw there was a retinal detachment, severe traction inferiorly, and there was a submacular foreign body. So I removed the oil here and tried to peel the membranes around. Did a retinectomy after cauterization. So I wanted to minimize the retinectomy, so I tried to evert the retina at this point, but I was not able to do it properly. Then there was one more adhesion which I had to cut where I had to cut the retina. So I was not able to evert the retina properly. So here probably the foreign body had ricocheted from this point. So there was a scarring at that point. And there we can see the foreign body just beneath the macula. So I made a large opening here. Took the magnet inside, just nudged the foreign body a little bit from the macula and taken it out. So patient was aphakic, already patient was aphakic, so I took the foreign body out from the anterior root. Settled the retina with PFCL, and I had to extend the retinectomy, and then I had done the laser, and so basically a very little bit of retina was left. This was a patient who was referred to me as a case of dropped cortical matter. When I examined the retina, there was actually a foreign body inside. So I induced the PVD with the help of tricod. And there was a capsulation over the foreign body, so I cut the capsule. Here we have to be very careful because there can be a bit of bleeding when you're doing this step. I had done cauterization around the foreign body and then removed the foreign body from that part. And taken it out with the magnet. These are my 3 videos.
Great, really wonderful. I should say you all make these difficult surgeries look so easy. Right, wonderful, wonderful recording as well. Thank you so much. Yeah. Okay. So I'll invite 2 quick comments from Dr. Anuruddha Maiti and Dr. Somdat Prasad, sir.
I think all of the videos were fantastic, excellently managed. I think in a foreign body is challenging. One challenge is to retrieve the foreign body, and another, the most important thing is to counsel the patient, because when the patient comes, the vision might be pretty good. But while taking that foreign body, if it is a subretinal, it is even more difficult, the vision might come down. So the counseling part is very important. The nature of the foreign body, you need to plan it before. The pre-op planning is very important, the type of the foreign body and your plan of surgery. And excellently managed, very nice videos.
Both the presentations are very good, excellent points made. We have to keep in mind this is not a surgery we do every day. So if you can do it very nicely, this is not your standard RD or your standard macula hole. You're doing it every day, you do it in your sleep. This you have to think. And I was just making a comment to say, when you get these patients, especially who come in, referred from somewhere, expect the unexpected. Like you said, I dropped nucleus actually had a foreign body, dropped nucleus, has a giant retinal tear, has something under the retina, everything. Expect the unexpected, plan for that. And counsel the patient, very importantly, because our patients think that putting the lens is the end of surgery. And I tell them, I'm not going to put your lens. I'm going to take this out, I'm going to stabilize the retina, let it calm down. There's risk of retinal damage, there's risk of PVR, RD if you've done a retinectomy like that. There are too many risks right now for me to add risk by putting a lens in. That will come out months down the line. So you counsel them. I did one yesterday actually, so it's all fresh in my mind. It counsel them, no, I will not put the lens in. I will only put the lens sometimes if it looks like it's going very nice. But generally lens is the least important bit of the eye. Please forget that. Let's get your retina stable. So with that point, I think it's just what you tell the patient before you go into the operating room. Then it's up to you and your skills what you do. Thank you.
Can I make a quick comment?
Yeah, please.
So it's actually, I agree with both the points Dr. Aniruddha and Dr. Som mentioned. Counseling especially, because it's not just the counseling, it's the documentation part also. You have to be very, very secure because these patients, it's very difficult to predict how they're going to progress even after you've removed the foreign body. You might end up with endophthalmitis, you might end up with a retinal detachment. There are n number of scenarios that can happen. So unless you are protected yourself, you are going to, and you have to obviously explain to the patient also, multiple times perhaps, because these are the patients that, just like Dr. Som said, you don't know what to expect, even during surgery. So the complications that can happen during retinal detachment are comparatively, see, when you're doing cataracts, your complications are expected most of the times. What can happen, what can go wrong? When retinal detachment surgeries or retina surgeries, you have a fair idea. It's these foreign bodies that you have absolutely no idea what you're going to land up with next. So you have to be very, very careful at each step.
Thank you so much. Very insightful. And let us invite our next two speakers, Dr. Ghazal Patnaik and Dr. S.S. Chaudhary. Dr. Ghazal Patnaik is a consultant at Shankar Nethralaya, Kolkata, and Dr. S.S. Chaudhary is with RIO, Kolkata. And they will be talking on VKH and immunomodulation. And this is something very interesting, and many new things are coming up, and we need to keep ourselves updated through them. Let's go ahead. And the first talk will be from Dr. S.S. Chaudhary. And the discussions in these topic will be Dr. Devasis Das and Dr. Tripti Konti. Right. You know, in the meantime, by the time they load, okay, they're ready. Dr. Chaudhary would speak first, yeah.
Good morning, everyone. I would like to speak about the immunomodulation therapy on VKH. I like to present one case from that. Greetings from RIO Kolkata. We had a patient named V, which is 62 years of age, presented to us with a visual acuity of hand movement of both the eyes initially. And he had a history of bacterial meningitis 7 months back before he came to us, followed by a hearing loss. Then he consulted an ENT. And he had a sensory hearing loss, which was proved on the PTA report. After that, he had complaints of vitiligo for the last 6 months, and then redness and dimness of vision for the last 6 months. On the examination, we could see the poliosis of both the eyes, and the anterior chamber was quiet. There was a cataract, but the cataracts were not so dense as evident in the slit lamp photography, and there was iris pigments. Now, the fundus photograph of the right eye showed exudative retinal detachment. In the left eye, there was a blurred disc margins along with the Dahlen-Fuchs nodules. The OCT of the right eye was only taken because the left eye cannot be procured due to the media opacity. The right eye, there is no significant OCT changes. But in the DFA photograph, we can show initially there is a rim of hyperfluorescence followed by a rim of hyperfluorescence, and the hyperfluorescence gradually increased in the size and intensity in the latter part. Now, there was exudative retinal detachment of both the eyes, which can be appreciated on the USG-B scan. So the initial management, we sent for a vitreous biopsy. All the PCR report was negative. We started on IV methylprednisolone followed by oral steroid, and along with oral SZA was initiated at 125 milligram per day dose along with topical steroids. So after 6 weeks, the USG scan, we can see that the exudative retinal detachment has been resolved spontaneously. In the meantime, we never operated for the cataract. Operated with the cataract, and after 6 weeks, the visual acuity for the right eye was 636 and for the left eye was 660. And on the fundus photography, the exudate resolved and the disc edema was absent. So the clinic message is that immunomodulator therapy can be started as a first line of therapy along with steroids for a superior visual outcome as well as a quicker visual outcome rather than a steroid monotherapy. So thank you.
Thank you, Dr. Chaudhary. That was wonderful. And we will take the comments after both the talks. So let us invite Dr. Ghazal Patnaik to go ahead with her presentation.
Good afternoon, everyone. At the outset, I would like to thank Sudipta ma'am for this opportunity. And without wasting much time, I would like to jump to the topic VKH and immunomodulation. So it's a 5-year story of a young male, 32 years male. At 2018, he was diagnosed with VKH. And from 2018 to 2021, he had been having recurrent attacks of redness, pain, headache, and a complaint of diminution of vision in both the eyes. He has been visiting multiple eye care centers and has been prescribed topical and systemic corticosteroids. So when he came to us in March 2022, the best corrected visual acuity was counting fingers, closed face in the right eye and 2200 in the left eye. And we had a posterior synechia and a sunset glow fundus with exudative retinal detachment in both the eyes with subretinal fibrosis in the right eye and peripapillary CNVM in the left eye, which can be appreciated in the ultrasonography with increased choroidal thickness, and there was macular edema in both the eyes. So he was started with 3 doses of pulse IV methylprednisolone, and the vision did not improve much. So we decided to give 3 doses of adalimumab at this stage. Vision improved, but due to financial constraints, patient could not afford much of the adalimumab. He was simultaneously started with azathioprine and tapering doses of systemic corticosteroids as well. So when we revisited him in July 2022, vision improved. However, he has been started on tofacitinib leflunomide along with Visolone because he was not able to tolerate azathioprine at all. At this stage, there was resolution of retinal detachment in the left eye, but there was a persistence in the right eye. Choroidal thickness was reducing, and there was persistence of subretinal fibrosis in the right eye. So this continued, and after 5 months of this biologics and everything, finally we had a resolution of retinal detachment in both the eyes, choroidal thickness was controlled, and there was a resolution of macular edema. However, the vision further deteriorated and it became counting finger 50 and 1 meter due to development of cataract. And the patient is doing well on the fields of inflammation, maintained on tofacitinib 10 milligram with a maintenance dose of 10 milligram per day of Visolone. So finally inflammatory control was done after so much of battle. So what I would like to highlight here that VKH do respond very nicely with the steroids, but immunomodulatory therapy early in these courses is very, very important. It's not about 6 weeks, 6 months story. It's a chronic disease. So whenever you get a complicated situation like sunset glow fundus, CNVM, subretinal fibrosis, just jump to aggressive immunomodulatory control. Thank you.
Thank you so much. Without much ado, let us take comments from Dr. Devashish Das and then from Dr. Kauntaya.
Very well presented. I just wanted to know how you are correlating the bacterial meningitis with your VKH. You have started your first case with the...
He had history of bacterial meningitis.
No, is it correlated to your presentation?
No, not directly
not
correlated.
directly. Number one. Number two is azathioprine, usually we give in 50 milligram tablets, no? 50 TDS. Usually we start with 50 TDS.
You can give to 100 to 200 milligram in divided doses or a single dose. So we started with 125 milligram single dose. usually doses in the schedule is 100 to 200 milligram. Either you can give a single dose or in divided dose.
Okay. Okay. And as far as the Ghazal's presentation, the last slide I've seen is CNVM, is it persisting?
Yes, sir. But it is not active at present. We did FFA
It's not
also.
active.
Not
There's no
active.
fluid.
Yes.
Only the membrane has been
Scarred,
there.
yes, sir.
Correct. Nice presentations. Thank you. Tripti.
I agree with both the speakers. It's very, very important to start immunomodulation right at the beginning of the treatment, because VKH is a long, long battle, especially in young patients where you do not know what will happen to them. And another very important thing with immunomodulation, so monitoring the blood counts and other factors are very important. Recently, I've had a patient who just started Azoran and landed up in ICU with cytopenia. So yes, and I will also request Dr. Somshila ma'am to give her valuable opinion.
Yeah, I think it's very well presented. Both the speakers spoke pretty well, and you took the sequence from your case to an overview, so that was the walking hand in hand. And of course, the onboarding of patients for immunomodulators has to be right away in cases like VKH and any other of these chronic uveitic entities where we expect to use steroids. We need immunosuppression for any length of time. And as a thioprin, that when you were discussing with me, I just realized that this could be the case of the patient who has an enzyme deficiency, and that's why the patient could have landed up in cytopenia. But otherwise, we have a lot of safety with many of these immunomodulators, and some of our patients, we use it we started ourselves because they don't have access to rheumatologists and so on. But with the newer drugs, like in your case you showed, that there I would definitely take the help of rheumat colleague for sure. But most other patients, we are treating them ourselves, and we need to.
Excellent. That was a great discussion. I was just wondering about one point. Okay, Dr. Saurabh Sanal has a point. Let him finish and then.
Not bacterial meningitis, but aseptic meningitis is common in VKH. It can present with aseptic meningitis, not bacterial. So whether it was a aseptic meningitis or bacterial, you have to find out.
Okay, that was a great input, and I was just wondering, like IMT has really come of age, and we really, for all NIUs, we really think of it, and most of the time it's being very well used judiciously. But I was wondering, what do you do when there is a pandemic of COVID proportions? How do you manage these patients? It's a difficult situation, I believe.
Absolutely. So during COVID, just like many other diseases, there were guidelines for us to use which immunosuppressants and how to monitor. So methotrexate was considered the safer one, and was definitely, we could monitor only during the time of vaccination. There were some guidelines on how to stop it for the time being temporary. And oral steroids, yes, also, except for the second phase where everything just went haywire for all of us. But otherwise, mostly the access to immunomodulators was the problem that we had for the patients. But there were guidelines that came out, which was again a good learning exercise for everyone.
Cost of the medicine is very much unaffordable by the patient.
The cost of methotrexate is very affordable. So
No, not that. I mean, immunomodulator is all right, azathioprine, but biologics is very costly.
Even with biologicals now, we have because of the biosimilars. Some of these conditions are vision threatening. Patients go blind, and the oral steroids are extremely
And the systemic complications.
No, so the biologicals are actually not that expensive anymore. Each infusion costs around 8,000 rupees. Sometimes the patients need about 6 infusions, and it can save vision. So I agree with you that there is a cost involved. But when you look at how everything is expensive, if somebody goes for a cardiac evaluation and for stenting, and nobody thinks about spending that much for a cardiac problem where you have to save life, but here you have to save vision. So for that, I think the cost is justified. And safety, I agree that it cannot be done by us. It has to be done by the specialist.
Thank you. Before we end the session, let us have the take-home message from our chairperson, Dr. K.P. Ghosh, for all the talks.
Actually, the take-home message has already been said by all the, nothing more to add. But sincerely, I thank all the speakers for their excellent videos and excellent presentation.
Thank you, sir. I think Dr. B.N.R. Subodhi's keynote address has already been delivered. So over to Dr. Sudipta.
Thank you, Siddhartha. We have a small sponsored talk by Dr. Tania Roy Bhatro after this. Dr. Tania, please come over.
So good afternoon, everybody. Today my topic is an ideal adjunct in glaucoma management. Approximately 30% of patients starting glaucoma therapy will require adjunct therapy within 1 year. So which should be the ideal adjuncts? Dorzolamide, brinzolamides or brimonidine? So alpha-2 agonists give additional IP reduction ranging from 15.5 to 20.1% when added as an adjunct. We all of you know the carbonic anhydrase inhibitors, they are safe and generally well tolerated with an IP lowering efficacy 15 to 20%. So now effect on IP lowering. Dorzolamide versus brimonidine when added to the timolol in 24 hours efficacy, and DTFC significantly reduces IOP more than BTFC in primary open angle glaucoma. So dorzolamide versus brimonidine when added to timolol in 24 hours efficacy. Both fixed dose combination significantly reduces the 24 hours IOP in primary open angle glaucoma, and the DTFC provided significantly better 24 hours IOP lowering efficacy than BTFC. So next is in dorzolamide timolol versus brimonidine in nocturnal IOP reduction. Brimonidine also showed significant IOP reduction except in 3 time points, that is in midnight, 3 am and 6 am. So the dorzolamide timolol was more effective in 24 hours IOP reduction than the brimonidine, which was less effective particularly at night. Now dorzolamide versus brimonidine, the another study where the DT provides the greater mean IOP reduction from the baseline than BT. So dorzolamide provides an additional IOP reduction when used as an adjunct. As adjunct to brimonidine, additional 29% IOP reduction. As adjunct to tavoprost, additional 21% IOP reduction with latanoprost 20% and timolol 10% to 18% IOP reduction. Now effect on ocular blood flow. So is actually well controlled patients or actually well controlled? So the ocular blood flow is linked to the structural damage in glaucoma patients and causing progression, and treatment of glaucoma patient for such as non-IOP risk factor is an unmet medical
30
need.
seconds more.
Okay. So as per meta-analysis published in Survey of Ophthalmology, topical carbonic anhydrase inhibitor increases the ocular blood flow in the retrovalvular vasculature and also increase the ocular blood flow in the retinal circulation. So dorzolamide improves ocular blood flow better as compared to the brinzolamide because optimum pH and the lipophilicity ensure better penetration in the posterior segment and increase inhibition of carbonic anhydrase enzymes. So this is a review of topical carbonic anhydrase and the visual function in glaucoma and ocular hypertension. So
Just rush through the slides,
effect on
come to the
progressions.
conclusion.
So patient with an DT have a significant lower risk of progression from the patient with an BT. Comparison on the safety and tolerability, conjunctival hyperemia is more frequently reported in association with brimonidine timolol compared to the dorzolamide and timolol therapy. And all of you know the most common side effects of brimonidine is an excessive sleepiness, lethargy, eye itching, rubbing. So the take-home message, additional IP lowering therapy should be considered when the patient IP is not a target patient or when progression is detected on structural and functional testing. And use of multiple drops with an preservative can result in ocular surface disease. So this can be managed with an use of preservative-free version of the drugs. Thank you.
Thank you, Tanya. With that, we come to the end of the scientific sessions.
Thank you so much. Now, for this last session that we had in Retina, I would request our President, Dr. Ratish Chandrapal sir, to come and hand over a memento to Dr. Kajal Prasad Ghosh sir. Can I have a round of applause, please? Thank you. These are the main persons. And sir, please do not go. Please hand over a memento to our President of OSWB, Dr. Tishandra sir. And now for the panelists. Sir, please stay there. Hand over a memento to our panelists. Dr. Debashish Das, sir. He is not only a panelist here, but also our Honorable Secretary of OSWB. Dr. Tripti Kauntia, panelist. Dr. Aniruddha Maiti. Dr. Vivek Datta, is a plain actor. Dr. Vivek Datta, sir. আর একটা কোনটা খালি আছে এটা তো নেই এটা তো yeah and Dr. Somnath Prasad Somnath Prasad তো থাকবে আচ্ছা নালে দিয়ে দাও Dr. Somnath Prasad and the speakers Dr. Sneha Jain. Sneha, and walking hand in hand with Shoman Mondol. Shoman Mondol. Please come, please come. You both walk together. Come. And a photograph, please. Yeah. Dr. Sneha Jain, can I have a round of applause for her?
Just change the mood, let me say. Change the mood with the medley from Arijit.
Dr. Shoman Mondol. You should stand together for a photograph at least.
It's a mix of
Hello.
And next we have Dr. Piyush Bansal with Dr. Sangeeta Rai. Where is Piyush? Dr. Piyush? He's always. Dr. Ghazal Patnaik and Dr. S.S. Chaudhary. Dr. Ghazal and Dr. S.S. Chaudhary. Ghazal. Yes. Dr. S.S. Chaudhary. All have left the hall. Why? Okay. And the last but not the least, Dr. Siddhartha Ghosh. Please, our moderator of this session.
And now to our convener and the person who has conceived the whole program, Dr. Sudipta Mitra.
I'm only starting. What? This is just an introduction, and then I will see that LBU journey with you. And then
Are they there? Dr. Shagnik?
Yes.
Dr. Shagnik?
Yeah, introduce you because you are the one. I said thank you.
Shankar Shubra. Okay. Dr. S.S. Chaudhary. Yeah, please, please. Oh, he's sorry. Your videos were. Can I have a round of applause? Dr. Sir, Dr. Debashish Bhattacharya, sir. He was there, but anyway. এখন দেখাচ্ছেন ডক্টর কি করে নিলে নিচে আছে then done. Okay, good. Acha, this program wouldn't have been possible without our sponsors, I think, of course. Shipla and Entod, I would request, Sir Bhushan, I would request their managers to please come up, and I request our OSWB Secretary, Honorary Secretary, and Scientific Committee Chairman. Okay, so please come over. Go for. Can I have a round of applause for them? Thank you, Cipla, for sponsoring this session and for Enter. Yeah, what is
myself Arijit Das and
Shuman Chakraborty.
From the two divisions separately.
Cipla, you did not introduce yourself. Come and introduce yourself.
Hello, good afternoon. I'm Rishikesh, Area Business Manager for from Cipla, Kolkata for Site Team 2. And I'm very much glad to receive this memento, and I'm always thankful to Sir and OSWB for giving such wonderful mementos to Cipla. And we are always keen to participate in any kind of educational program in future also with collaborations with OSWB, ma'am. Yeah. Thank you so much, Sir and ma'am.
Thank you.
Piyush, are you there? Dr. Piyush Bansal? Okay. Sir, yeah. One group photograph, sir, do not go. The one group photograph of the retina session. The speaker, panelist, chairperson, Shomda, please come over.
Hello, check. Hello, hello. Hello, check. Hello, hello, check. Hello, check.
Dr. Shubhashachi Patnaik was missing when our national faculty
Hello.
was there introducing
Hello,
themselves.
check.
So
Hello,
just
hello,
after the
check.
photograph, we can just have 1 minute to.
So respected seniors and my dear friends, I am Dr. Sabyasachi Patnaik from Odisha. I was the state honorary secretary of Odisha State Ophthalmological Society, and now I am chairman scientific committee of the IJOC. I need your blessings because I am contesting for member ARC East Zone. Why I am contesting? There are two reasons. One is I tried last time and I got the support of and blessings of most of you present here, and I marginally lost. So this time I am again requesting for your blessings and support to me, number one. Second, what I have done during, because I have not done personally anything for me to achieve any heights or something, because during my tenureship as secretary OSOS, we had this COVID. Then we thought of having how to continue this training and teaching program of the ophthalmologist and residents. So we started ORTS, Ophthalmic Resident Teaching Series, and Ophthalmic Research and Publication Series in our state. And we found out it got lot of benefit to the residents and also general practitioners. Many of you present here also have attended those programs, and we could able to publish many papers from our state by the residents. Now under the banner of IJOC, I have also started with cooperation of Dr. Professor B.N.R. Subudhi as the coordinator, those two programs. Now it has been extended to IJOC states and also beyond that. We have many residents attending and participating in this program. So with these ideas in mind, I want to serve a little more as member ARC from the East Zone. So that's why I request all your love, affection and blessings once again for this post. Thank you very much. I will be obliged to all of you personally. Thank you, sir.
So please do not go. Now is the most interesting part of today, the Life Beyond Ophthalmology session. And who else? None other than Dr. Harshul Tuck is going to take over. Can we have a round of applause for this? Life Beyond Ophthalmology has been popularized by him, and we all know how active it is. So all to you, Harshul Tuck, sir. It is all your session, so you introduce your
Thank you so much. Thank you so much, Sudipta, and I welcome all of you for this small session, which is going to be a kind of impromptu session, and we are not much prepared for this, but Sudipta told that we have to do something here, so I have with me Dr. Sohini Ghosh, who is my co-host for this session. And first of all, let me thank each one of you for showering your love, affection, and blessings for this wonderful group, which is vibrant only because of your participation and your involvement in this group. And Sohini, yes.
Thank you so much, Dr. Harshal. I'm sure that many of us will agree to the fact that as we mature, as we age, we understand the importance of hobbies. Hobbies which we are not so good at, which we wanted to do in our childhood, those little things, and live a full, complete, happy life and not just a productive one. So Life Beyond Ophthalmology gives us a wonderful opportunity to explore all our happy spaces. Now let us have a glimpse of Life Beyond Ophthalmology journey which has been happening so far.
So I'll be sharing a video that how the LBO group has done for last 3 years. So it was formed in 2019. I hope everybody will enjoy this journey. Can I have the audio, please? Audio from laptop.
Started on the social media platform Facebook, popularly known as LBO. A group started on the social media platform Facebook in November 2019 by none other than Dr. Harshal Tuck, the multi-talented, ever-smiling super doc from Jaipur. His idea was to bring together his friends and fellow colleagues on a single platform to showcase, nurture, and encourage them to live for their passion beyond ophthalmology. This journey, which began in 2019, was wholeheartedly supported by Entor, and today, group is 7,300 members strong and still growing. LBO and Live Your Passion have become synonymous thanks to his thoughtful gestures of sending out cards and prizes to encourage sharing of posts by all the members. It is these gestures of welcoming new members, recognition to the best post of the day, encouraging talents in various forms, which won the hearts of all the LBO members. The positive atmosphere, non-judgmental attitude, and inclusive nature has created a virtual space where we all meet, share, exchange, and encourage each other to live our passion. COVID times and lockdown days put our spirits low, but thanks to the efforts of Dr. Tak and many members, we saw a host of programs which brought us all together. We have seen a number of activities planned and executed, all thanks to his efforts and also the efforts of all the members to participate wholeheartedly and encouraging all other members too. We have seen magic show, stand-up comedy, painting workshops, cookery, photography workshops, rangoli and tattoo competitions, and also Ophtha Poets, which was a platform to showcase talents of our great poets. The lockdown special Ophthalmic Super Dancer Season 1 was a super success, which also led to the Season 2 a year later, and it was so amazing to see so much talent and effort poured in from all of the members. LBO Antakshari, a musical challenge for all the LBO members, was a super fun program to watch and even to participate. We heard melodious songs and instruments being played live during the LBO Mehfil episodes. The efforts of all the participating members has led to grand success of all the programs. LBO Dhamal, the first physical program of LBO, was held during AIOC 2022 at Mumbai. Songs, dances, Eyes on the Ramp, that was the first ever ophthalmic fashion show, was a runaway success. Over 80 participants and audience of over 500 who sat through 3 hours of amazing entertainment. The LBO Iconic Awards were given to Dr. Suhas Sarvade and Dr. Manish Nagpal, who are true icons inspiring so many others to follow their passion in art and photography. The midterm AIOC at Patna saw the second physical LBO program in January 2023. The theme for fashion show here was of national integration. Various participants showcased the traditional costumes from their particular states. And many took part in dances and song performances and even instrumental performances like tabla. overall a program for all to remember. We hope to continue celebrating different talents on LBO and keep up the motto, live your passion.
Thank you very much for showering your love and blessings to this group. And today,
Well, music is the language of the soul, the language of the spirit. And may I please request Dr. Harshal to present with a medley.
okay, I'll go first. Then Dr. Som, can I have, yeah. So I'll be doing a medley of few songs. And after that, Dr. Som will be sharing his wonderful photograph of wildlife photography. And if anybody wants to contribute, they're most welcome in between the show also. We would like to take up. And I hope that all of you would enjoy this and would sing along with me. Sudipta has done such a hard work, and now is the time has come that we all should celebrate the success of this meeting. So here I go. Start. Hello, check.
खामोशियाँ आवाज है, तुम सुनने तो आओ कभी, छूकर तुम्हें खिल जाएंगी, घर इनको बुलाओ कभी। बेकरार है बात करने को, कहने दो इनको जरा, खामोशियाँ तेरी मेरी, खामोशियाँ खामोशियाँ लिपटी हुई खामोशियाँ। इश्क जुनू जब हद से बढ़ जाए, इश्क जुनू जब हद से बढ़ जाए, हंसते हंसते आशिक सूली चढ़ जाए। इश्क का जादू सर चढ़ कर बोले, इश्क का जादू सर चढ़ कर बोले, खूब लगा लो पहरे रस्ते रब खोले। यही इश्क दी मर्जी है, यही रब दी मर्जी है, यही इश्क दी मर्जी है, यही रब दी मर्जी है। तेरे बिन जीना कैसा हाँ खुद गर्जी है, तूने क्या कर डाला, मर गई मैं मिट गई मैं, होरी हारी हो गई मैं, तेरी दीवानी दीवानी, तेरी दीवानी दीवानी। दोनों जहां तू रहे जिधर, मेरी जन्नत वही ढल रही अगन है जो ये दो तरफा, ना बुझे कभी मेरी मन्नत यही। तू मेरी आरज़ू, तू मेरी आशिकी, तू मेरी शायरी, तू मेरी मौसीकी। तलब 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 है मुझे बस तेरी, बसों में तू नशा बन के घुलना वही, तेरी मोहब्बत का करना तो हक यूं अदा, मेरी होके हमेशा ही रहना, कभी ना कहना अलविदा। मेरी वफा हो तुम ही और तुम ही शाम हो, तुम दर्द हो तुम ही आराम हो, मेरी मोहब्बत से आती है बस ये सदा, मेरी हो के हमेशा ही रहना, कभी ना कहना अलविदा। सी है रातें भीगी भीगी, यादें भीगी भीगी, बातें भीगी भीगी, आँखों में कैसी नमी है। आहा हा हा आहा 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 आहा, सपनों का साया पलकों पे आया, पल में हंसाया, पल में रुलाया, फिर भी ये कैसी कमी है। आहा हा हा आहा 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 आहा, ना जाने कोई कैसी है ये जिंदगानी, जिंदगानी हमारी अधूरी कहानी, ना जाने कोई कैसी है ये जिंदगानी, जिंदगानी हमारी अधूरी कहानी। Thank you and thanks a lot. And see, it's not a proper acoustic whatever system we have, we try to do. And after this, I'll invite Dr. Som Prasad here. We all know he's an prolific VR surgeon, and he's a wonderful photographer, and he loves wildlife photography and nature photography. We have seen his photographs many times, and I'll request him to showcase few of his photographs. Dr. Som Prasad.
Thank you so much, Harshul. Thank you, OSWB. Thank you, Sudipta, for asking me to be here. I understand people are waiting for lunch, so hopefully there'll be a bit of light entertainment before lunch. I was asked to speak on wildlife photography, but rather than go into why, how, etc., I'll mention a few points. I thought I'd just concentrate on one short trip we made last August. This, as you can see, is a polar bear, so you can imagine we are somewhere near the North Pole, north of Norway. Where are we? We are in a place called Svalbard. So that red dot is an airport called Longyearbyen. There's a small community of about 1,000 people, only 4 doctors in that whole community. It is the only place in the world that is administered by Norway, but it is actually not a part of Norway. So anybody can work and live there if you can get there without any permission or any visa or anything. So lots of interesting things. When you go out on wildlife photography trips, you learn a lot of other things as well. Anyway, so to get to Longyearbyen, we went to Oslo, and from Oslo we took about a 4.5-hour flight, which is apparently the longest domestic flight in Europe, to get to this place called Longyearbyen, because from there we were going to board the ship. These were the people with me. There were 12 people in the group, but 3 of us were traveling as a group, and you probably know them, Manish Nagpal, Shobhit Chawla. We go on quite a few of these trips together. So that's another advantage of doing this wildlife photography. You tend to develop your groups, and you become very close because you go out and do a lot of things together. We stayed on this ship for about 12 days. No communication, no mobile phones. There was a satellite phone for emergencies. We were about between 76 and 82 degrees north latitude, about 100 miles from the North Pole. So you can imagine, no communication, obviously, very difficult. This ship was built in 1955. It's an icebreaker. So when the sea freezes, it can actually break ice and go in, although it's no longer allowed to do that for environmental reasons. So only nowadays, only armed vessels will be allowed to do that. Navies can do that, but no commercial shipping is allowed to break ice. I'll come back to that in a second, why that is of concern. So we lived there. There were 12 people supposed to go as tourists. 11 went, one didn't turn up, and there were 5 crew. And that was it. So this was your group for those 12 days. 5 crew, including the captain, the engineer, the cook, and the 2 guides. And the 2 guides would also serve and do whatever. Inside was fairly basic, the places to sit, and one day they would set out the finer cutlery for a proper dinner. I don't know, a lot of you probably know birders, they have a target species. When they go on a trip, they'll say, this is my target species, I want to see that one. Well, obviously, if you go to near the North Pole, you want to see the polar bear. And they look like the original cuddly toy, but they're not the cuddly toy. They are, on an average, 700 to 800 kilos in weight, so they're big animals. A big male polar bear can be 1,100 or 1,200 kilos in weight. Interesting thing from a photographic point of view is that, we had talked about AI and ophthalmology and AI and all sorts of things now. Our cameras now have AI, so they automatically detect the subject's eye, be it animal or human or bird. And the reason for that is if you're taking a photo when you're being taught photography, learning photography, always learn, you must have the subject's eye in focus, unless you're trying something experimental, which is not the case. Because if the eye is not in focus, then the photograph looks uninteresting. So the camera automatically does this. But when you're photographing polar bears, what happens? Something happened in my presentation. This way. What happens, you can see the animal's ear. The animal's ear actually looks like an eye because it has this white hair around it and a black center. The polar bear's skin is black, although the hair is white. So the AI sometimes think the ear is the eye, but that's just a side interest piece. Now, when we take pictures, we normally, when you're starting wildlife photography, you want pictures like this, you want the whole animal, you want a close-up of the animal. It's often nicer to take pictures with a bit of the environment in it. So this is the background of the thing. There are birds flying in the sky. And perhaps a bit sadly, you're bringing up something which is very vital, is global warming. All this in August should be covered in ice. You shouldn't be able to see the rocks or the hills like that. It should be all white. Till 5 years ago, the pictures we've seen from there, they were all white. Now at about 80, 82 degrees north, there is no ice cap. The polar ice cap has really shrunk. It's not a story. It's not something somebody made up. Because we're interested in these, we've been planning this for 4 years. Then COVID stopped it, and by the time we went, we thought we would see everything white because what we had seen from friends who had gone earlier was like that. But at that same time of year, this is all gone. There's limited ice cover, and the polar bears have now, they normally hunt seal. Because if the sea is frozen, then they can go and catch the seal. The seal is sitting on the ice. But now, because the sea is not frozen, they find the polar bears are good swimmers, but not as good swimmers as seals, so they can't swim up and catch a seal. Won't happen. So they've started hunting reindeer. Their food habitat changed. They used to never hunt reindeer in the past. So again, it's not only photography, but you get other, as you do these things, you get interested in learning as to what is happening to them, what is not happening to them. This guy is prowling out on the lookout for what to eat, and he probably wants to eat this, which is a bearded seal. But like I said, this is on an ice floe on a piece of ice, and around it is all water with broken pieces of ice. It's difficult for the bear to get there. So this guy is happily lounging there, thinking it's all fine. Well, how do you get so close to get those photographs? You're sitting on the ship, it won't work. So what you do is they take you down in these little rubber boats. They are called zodiacs. They are made of rubber, strong rubber with an outboard motor. So you get into that, about 5 people in each, with one guide 6, and then they take you closer to that. So the reason why anybody wants to try it, do not go in a big boat which carries 100 people. It will be very luxurious, but your chance of seeing things will be very small. You go on a small boat like this, which is very much more basic, but the zodiacs are down in 10 minutes and we're in the thing in 10 minutes. So the captain says, oh, I can see a polar bear there or a nice colony of walruses there. Within 10 minutes, you're in the water and out. In a big boat, obviously, that will take 2 hours by the time that wildlife will have moved off from the place. So if you're planning your trips for these things, that is one thing. Make sure you know what you're booking and how it will work so you get what you want. And 2 is, please do not take anybody who's not interested in wildlife photography with you because it is intensely boring. If you're not into wildlife photography, all we are doing is going out, taking the pictures. When we are sitting back, we're on our laptops, sorting pictures and editing them. For anybody who's not interested, it is totally boring, besides seeing the scenery. So it's useful to travel with a group who are all into it. This is not a family holiday. It's not a luxurious 5-star holiday. This is a focused thing on what you want to do. So these are again the polar bears. Backlit, you try various photographic techniques. The light is coming from the back. You want an interesting picture. This is a bear family. And what you can see in front is a whale bone. That brown thing in front is a whale bone. What happens, the whales die, the carcass washes up to the coast. So it's on the beach somewhere, and as the water washes it in, it gets partly covered by rocks, and not rocks, these pebbly kind of things, these little stones and all. And that whale carcass is so big, it stays there for 2-3 years. The temperature is so low, it does not decompose or rot. And the bears know where it is, so when they don't find food, they will go back to where the carcass is. This was taken in August 22. I have very good friends who took the same scene in August 21. And I have another lot of friends who took the same scene in August 20. Well, not in the exact same pose, but in the same place, that same whale carcass, and bears there. So they will feed on it for 2-3 years in parts, because whales, as you know, are huge animals. So they keep it as a reserve. They come and they eat when they're not getting anything else, they will go there and eat. And they're very respectful. One family will come and eat, the other is there, they'll be waiting, they won't come and fight. These people go away, we saw them happening. One family came, ate, another one came up, these people then went away. That lot came and started eating. So they're very civilized in that way. But again, like I said, wildlife is not only about photographing wildlife, it's sometimes about photographing the surroundings as well. So if I'd taken that picture without the bear, it would be totally boring, but with the bear, it gives you an idea of what the atmosphere is like and what the bear is doing. And just to get off bears, there are other things, there are walruses. This walrus is also sunning themselves on this ice, bit of ice. And the bird coming in at the top, they're called fulmars, these birds. They're very popular, very common there. See them all around. They tend to come towards the ship, so you can play with taking whatever pictures you want of them. And then you see dolphins in the water. These are dolphins jump. You see those little black things, probably not that clear on the screen, but they're dolphins jumping. They jump out of the water and then go in again, come out. The bears have their own social life. They have various plays. They roll over like dogs do. So people who have dogs will know they roll over. Bears will do that sometimes. When they meet each other, they will do various things. So you learn to observe these things, see how they work. And also, you're taking the pictures, you're improving your photographic technique throughout. This is a walrus. Again, sometimes some things, people think wildlife should always be colored, but wildlife also looks good in black and white sometimes. I thought this picture looked much better that way, so it's there. And this guy is happily sitting there. Huge animal. Will go and pick something out and have a fish or something out and eat when it feels like, but otherwise basking around. And sometimes they give very human-like poses. This is a seal, actually. You can almost think of it as somebody sitting there with his hand under his chin, thinking about what am I going to do and what the world has come to. So, these things all, it's a matter of observation and then trying to frame it so that it tells my story or what I want to tell people, etc. Now, how do you do all this? Are you carrying a mountain full of photographic gear? Actually, no. If you remember, we don't check in our cameras, so we carry them on the flight. So the limit is 7 kilos in most flights, 12 kilos in business, which is actually not a lot when you're carrying photographic gear. So you have to select what you want to take. Also, when you're moving around, you have to take these cameras and go down into those boats and then take them and come up. If you're in a jungle safari, you have to handle them while you're in a moving jeep. So all this fancy business of taking a huge amount of kit doesn't actually work. Unless you're absolute pro and you have 3 jeeps to yourself, you're working for Nat Geo, BBC Wildlife, and find everything is done for you. But if you're doing it yourself, that doesn't work. So you have to select what you want. My typical kit, that's from a few years ago, but my typical kit is 2 camera bodies. The bodies have changed now, but just to give you an idea. One with a 70-200 lens, and one with a prime lens. This is a very nice small prime lens. This is a 300 mm. On that particular body, it gives me a 450 mm effect, which for animals is long enough. And it's like you can carry it in one hand like that. So you have to decide what you want to carry, because you'll be juggling things. There's a small camera in between, which I strap to my belt. Either that or a Leica around my neck, whatever, a small light one, which is for the atmospheric shots, for the wider angle shots, because the longer lenses will not do that. So you're pretty mobile, you can pick one up, one of your big bodies up, keep it down, pick the other one up, and then don't forget your smartphone. The modern phones are very good cameras, so if you're taking a landscape, you can do it with your phone, and it will give you as good a result. Not for the close animal shots. Have I used up my time, Harshul, or are we? We have, more or less. Yes. Thank you. So there are just a few tips of how to do some things and some of the resulting images. Thank you.
Thank you so much, Dr. Som, for those wonderful photographs and sharing your journey. And Sohini,
Yeah, it was indeed. I mean, each photograph had a story of its own. He has beautifully explained the story behind it. Now, may I please request Dr. Saurabh Sanyal sir? And it is said that every canvas is a journey of its own. So he is a prolific surgeon, and apart from that, he is a wonderful painter. So let's be a part of his journey.
Thank you, OSWB. Thank you, Dr. Harshul, Sudipta, and everybody for giving me this opportunity to showcasing some of my work. That actually I used to paint during my school days, college days, but after that there was no time when we were trying to build up our career. But fortunately, lockdown has given us some time to come back to our passion. So during lockdown, actually, I started learning again. I do my classes every Tuesday online. I don't go to a painter's workshop because it is not possible. But every Tuesday evening, 3 to 4 hours, we sit on an online class, and 4 ophthalmologists in that group. One from Chitrakoot, one girl, and one from California, one girl in my group, same group. So they are all learning these paintings. So the art actually washes away from the soul, the dust of everyday life. That's a very nice saying by Pablo Picasso. So I normally, what I do watercolor, nothing else, or some your graphite, pen and ink, this sort of thing. No oil, no pastel. Still now I'm doing only watercolor. Watercolor is one of the difficult thing to do in artwork, because there is very less chance of correction in watercolor. In oil you can rebrush, you can erase, and you can create another in the same canvas you can do. But in watercolor you have very less chance of error, and your mixing of colors is basically not in the palettes, basically on the paper. So you have to choose the proper paper also. Those who are interested, they can have a guide from us that how to choose papers, because these thick papers only can work well, or not these regular papers. There watercolor is not possible. And your brushes and your different kinds of pencil and pens. So I normally do a series. I try to do a series of different things. So to start with a very common thing of Durga Puja. So this is your Torpon. We started with the Torpon. Then in your Kumatuli, the Murti is under making. Then these are the very iconic picture of Bengal. This is the Dhakis, the single or 2 people. Then the Murti is going to the Pandal. And this is the Chakshudan. This is a very important ceremony in our Durga Puja time. These are the Kolabo Snan. This is the beginning of this festival we do. And this is Sandhi Puja of Mahastami. And this is Navami, the Dhunuchi Nach. This is again Arati. And this is again a Dhunuchi Nach. And lastly, the Visarjan. So, and there are few of different moods of Durga. This is one in the villages, and this one in a jamindar house, and that one in a village house. So now come to some portraits. So these are the portraits I made. This is Kumaoni lady. I visit to Mayavati every year. So I have some pictures of those Kumaoni ladies. So I've made one. And this is a Rajasthani folk singer with his musical instrument. And this is a monk from Himalayas. And now these are a few from our cityscape, basically you say, the rainy days. And this is typical of North Calcutta Gully. You will find this kind of things in North Calcutta. The beauty of this learning is that the perspective of this paintings, the depth of these paintings. This is typical of during our rainy days, and this is a gully in North Calcutta. And these are of some photos of Calcutta. This is Victoria Memorial with the buggy, and the couple is going there, and this is also a kind of in a cycle. So some articles you see every day and you try to paint, it is very difficult actually. Because of this perspective, because of this positions of the cycle, so we have to, these are the difficult things. So this is two from iconic building of Calcutta. This is New Market, the Hog Market, and this is Park Street during Christmas celebration. And this is one of my favorite pictures, winter setting in, the boys in front of Victoria, and there's this winter setting in there with the fires sitting there, and the yellow iconic taxi of Kolkata. These are two from the hills. One is in the village, this thing, and one is the typical, this tower of Darjeeling municipality. This is the clock tower of Darjeeling. And now few photographs of Ganga Sagar. These are the few favorite things for all artists. We see this kind of paintings. This is the morning in the Ganga Sagar puja during this sadhu. This water sprinkles are very typical of Ganga Sagar. And this is Banaras during night time, that one. And this is Bismillah in Banaras. This is Kedarnath temple, and this is Badrinath temple. And this is Lord Jagannath Ratha Yatra of Puri. These are two from Harsul's place. This is typical of Rajasthan. This wash paintings, and this is Apollo. These are few watercolor on some Ganesh, Hanuman, and one of the Vishnu Murti of bronze, trying to get the effect of bronze. These are the ethnic different type of painting. One is your Rajasthani folk painting like this, different forts, they have this kind of paintings. And this is Madhubani art. This is the creator and the creations. Narayan Devnath with all his characters, and Mr. Hertz with Tintin. And this is National Celebration Day of 26th January and 75th Azadi Ki Amrit Mahotsav. This is World Tiger Day. So I told you that I tried to make an event, and then this is your Guru Purnima. The day we painted it is Guru Purnima. And this is a northwester's wind in a Calcutta city, and this is Holi. And I am fond of drawing this cars and vehicles. So there are a series of that. This is a buggy waiting for a passenger in front of Victoria. This is typically a yellow taxi in front of Victoria. This is the Calcutta tram in the backdrop of the churches. This is the double-storied buses, and this is typical of ferry service we cross in Howrah. This is the steam engine of older days. It's not seen now. And these two are the architectural building of Kolkata. This is College Street Coffee House, and this is Star Theatre from a different angle. And these are two, one is village portrait, village scape, you say, and one, this is a friendship day. This was the, when they were young, the photo of that, and now at this age, they are sitting and talking. This is the World Friendship Day, we painted that. So to end, that art helps to take your mind off stressful situation. Creating art is a great way to take your mind off the stressors in your life. When you create, you engage a different part of your brain, and you can get caught up in what you are creating. Even if you spend 45 minutes on art, it will clear your head and allow you to approach the problems from a fresher perspective. This is the last 14th Valentine's Day I painted, and I kept it last because hand in hand is the today's program, so I kept it that. Thank you very much. Thank you all.
Thank you so much, Dr. Sanyal. Those were wonderful paintings by you, and every painting had a story. And so how many days it takes for you to finish one painting?
I try to finish in the evening only.
Okay, okay.
Because next day it is not single evening I complete one. Sometimes some leftover I do next day, but it is not possible for sitting next day again with the same painting. So I try to do it in the same sitting.
Very nice. Thank you so much, Dr. Saurav, for sharing your wonderful paintings. And now we have Dr. Saket Jana. He is an amazing painter as well as a photographer, and today he'll be sharing on composition in photography, how we can improve composition of our photograph, because composition, we all know, is everything in photography. So let's hear from Dr. Saket that how we can improve composition. So Dr. Saket, you paint also, and you do photography also. But the depth and 3D effect which we see in painting, it never comes in photograph. Why are you shifting from painting to photography?
Good afternoon, everybody. Thank you, Dr. Harshul. Thank you, Dr. Sudipta Mitro and OSWB for giving this opportunity. Having cell phone in our pockets, we all are photographers. But today, I will be talking on composition in photography. First of all, we should know what is composition and why is it required for a photography. Composition is nothing but an arrangement of elements in a particular frame or image. It refers how the objects of particular frame reacts with each other. And it is the basic technique required for all types of photography and all types of devices. It is required to define our subject, to create a wow factor in our photography, and also it is used for storytelling. Now let us discuss about some of the composition rule. First of all, as you see, the first and most commonly used rule is rule of thirds. Here the screen is divided 2 vertical and 2 horizontal equispaced lines, creating 9 rectangles and 4 intersecting points. As a photographer, we should try to keep our subject along these guidelines and also along within the intersecting point. In the first picture, it was taken from a hot air balloon to the other balloons, but I tried to keep the subject or the balloon in a particular grid or particular guideline, so it gets visually more appealing. Next picture, it is a mobile picture at Rajarhat. I intentionally kept the trees in the center of the picture, but we should try to these trees in the guideline of third rule of third. So it gives more pleasure to eyes. Another example of rule of third, you can see this butterfly, this flower with bee, and even a street photography. Next rule is the rule of reflection. Whenever we are thinking of some photography here and there, we should try to find out a mirror or a waterlogging water body so that we can create a reflection of our subject or background. In this picture, simple picture is a common picture from Kerala, that these coconut trees, but with the reflection in the water body, it creates a different effect to eyes. Another example of reflections, this is Mount Abu, Nakki Lake. Here we can see the reflections. Next point is symmetry and balance. For the architectural photography, we should try to keep some balance in the keeping the subject in the center. In the first picture, not only the both sides are balanced, but also the upside down creating a reflection also balanced. But the previous two pictures are almost symmetrical in both sides. But in this picture, it is not symmetrical, but still it is somehow balanced. And same for this picture too. But if we see the Eiffel Tower, it was taken from river scene. But here the Eiffel Tower kept in one side, though I tried to keep the 1/3 rule, but here this rule is not very applicable. And we can understand that the left side of the picture is demanding something more. So it is a lack of balance in the picture. Okay, next, foreground interest. While we are taking a photograph of particularly landscape, there must be three fields: foreground, middle and background. This is a simple picture, nothing very special here, but keeping the foreground objects like these stony structures in front, it creating more visual effect to the audience, to the viewers. Next picture, here all we can see the pyramid in the background, camels in the middle ground, and the horse in the foreground. It what actually the 2D picture giving a depth of 3D, three structure in 3 level. Another example, this is an example of distracting foreground. Here the foreground is so prominent, we actually lost our subject. For mountain photography, we should keep in mind, we should try to capture the layers. Here also the foreground, middle and the background comes into play, but we should try to keep the layers of the mountain, and it creates more visual effect to the viewers. This is a Himalayan range taken from flight to Leh. Whatever picture we take, this is a frame. But if we try to keep our subject within another frame, then it is called frame within a frame. And it creates more, actually it helps the viewer to focus on the subject. The first one at Budapest, second one at Leh, and the last one is Austria. But here, all these previous pictures, the frame was man-made. But here, I tried to create the frame with this tree and its branches. This is another natural frame, you can say. In next picture, this is also natural frame with bamboo trees. But here another point is that there is a leading lines. Leading lines are those lines, it actually helps the viewer to target the subject, to see towards the subject. Here we can see the green lines, all arrows are going to that red cyclist. These are leading lines. Another good example of leading lines in this picture, it was taken at Jhargram. This picture was taken from Eiffel Tower, the beautiful city of Paris. That black, large, tall building, actually at the time of taking picture, I was not aware of these leading lines, but later on I see that yes, it is good example of leading lines. The rows of building, the architectural lines, all that pointing towards the black building. Next rule is pattern and texture. Wherever we go, there are some structure which are very repetitive in manners, either in regularly regular or irregularly regular. Even this carpet has a pattern. So this type of pattern creates more visual effect, more visual impact to the viewers. We can keep it in the picture. Another example of natural pattern, there is a waves in the sand. And I tried at Kumartuli to capture a atypical pattern. Now, other geometric structures, diagonal, triangles, all can come to in composition. Besides this, these are the dynamic space and the dead space or negative space is required. We should try to keep more space towards the direction of the view of the subject or towards the movement of the subject. Now, while taking photograph, all of us usually try to focus on the subject. But photographer should keep an eye regarding the background of the subject. A clean background creates more prominent effect towards the subject. In the first picture, the background is defocused, but it is cluttered. But in the second picture, background is very smooth and soothing to the eyes. Here, background is used, it is an example of travel photography. Here, the background is used to attract the viewers so that viewers should try to go there, but it attracts the place. Now, placing the human element in the picture. In this picture, we can see a countryside from Germany, Munich. Here all we know the size of the human being, and by these we can understand the scale of the picture. Another example of human element, this is a Pangong Lake, and by placing the human structure, we can understand how big is this. But too many human structure will clutter the scene. And as a photographer, we have to keep some patience regarding some action, to capturing some action. We have to keep our camera ready. We have to take our place properly to capture a repetitive works and a particular decisive moments, and that creates wow effect to your picture. Almost all camera is having panoramic mode. We can use this panoramic mode for a wide structure, wide architectural structure. The first one, Karnak Temple, Egypt, and the second one is Louvre at Paris. Now come to conclusions. There are many more rules on composition, golden triangle, golden ratio, etc. But these are little bit of complicated. And these all I have told the basic rules in photography for the beginners. We must keep in mind the rules are made to be broken. So first we have to practice the rule to break it later on. So be innovative, be creative, be conceptual, and create your own rules. Thank you very much for patience.
Thank you so much, Dr. Sekrit, for telling us everything about composition, how we can improve our photography. And of course, once you master it, there are times when we go out of the box and do creative, you have to be creative in photography and everything you do. Yeah. Thank you so much. And with this, I think we end this short session. Thanks a lot, Dr. Som Prasad, Dr. Saikat, Dr. Saurabh, for sharing
All of
your...
you can stand together for a group photograph.
And Dr. Sudipta, thanks a lot for giving this wonderful opportunity. Please come here.
And to hand over a memento, which was left, Shoikat, please come over. Sir, Shoikat, please come over.
Yeah, Dr. Ratish Paul to please.
Our President, Dr. R.C. Paul, sir, to hand over memento to photograph, please. Beyond ophthalmology, please come over for a group photo. With that, we come to the end of the day. With this, we come to the end of the day, the session of LBO. I thank each one of you from the bottom of my heart to be here. And our President, sir, who has been, from the very beginning, he has been with us. Our Secretary, sir, our Scientific Committee Chairman, Dr. Rupak Kanti Biswas, who has given me this opportunity to conduct this session. And all who have taken all the pain to come over here from long distances, Dr. Srini, Dr. Piyush, everyone, who are Dr. Harshul, who has very nicely and very vibrantly wanted to conduct a LB. I'm sorry, it might have taken a bigger amplitude if we had more permissions, but again, there's always a next time. And the pharma companies, each one who has taken the pain to be here today. Thank you so much. We wish to see you again in some other platform of, in some other CME of OSWB. Till then, stay safe, stay healthy. Sir, you want to add anything? I want a round of applause for our audio-visual people who have done a phenomenal job. Some of them have really stayed up long hours. Thank you so much. Thank you so much.